Right, my dear lovely friends, a very, very good morning to all of you, great doctors of this country. Dear friends, before we start our discussion today, I would just like to discuss a few questions here. Uh, those students who have joined earlier and who appeared for the yesterday's Tuesday test, just a few questions from there. There was one question where there was a mistake, like that was a question of Raynaud's disease, where you had an image wherein in the question ideally it should have been mentioned that which of the following is not true, and then the correct answer would have been the D option for that. I would just like to take up a few questions quickly, beta. Let me just check. I think a few of you have asked your queries. Like, actually, there was a typo error in the question, what I'm seeing here, that which of the following classical color changes shown in the given image. So if this is the question, then the answer would have been A. The classical color changes would have been white, blue, and red. So all of you who have marked the answer A, you are absolutely correct, and just add 1 mark to your score. However, the actual question was which of the following is not true about the disease pathology wherein the classical color changes are shown. So we know the characteristic sequence of color changes is white, blue, and red. Primary Raynaud's when there is no other disease associated, and secondary when it is associated with some other diseases like SLE, rheumatoid arthritis, scleroderma, thoracic outlet syndrome, cervical rib. Usually involve the upper limbs, that is right, but radial pulse is normal in Raynaud's because Raynaud's is a disease affecting only the arterioles. So if the question would have been not true, then the answer would have been D. And that was the actual question, but my mistake that I did not cross-check it at the last moment, and it went without this. Now, so you get 1 extra mark. Please add 1 extra mark to whatever score you have got. Then there was a question wherein I received a lot of queries regarding the least likely possibility in the patient. There was a question which was framed as, suppose there is an injury to the left side of the chest and the left upper abdomen. And there, what happened, the clinical scenario was more of left hemothorax. That was a clinical scenario, I guess. Yes. But the examiner, what he asked in the question was, which of the following is least likely to happen? मतलब कौन सा इलाका ऐसा होगा जिसमें चोट लगने के चांस सबसे कम होंगे? The question was like this, right? And what we did was, it was a lengthy question. The examiner was just trying to test your patience there, and you missed out on the word least likely, right? And you marked the answer as left hemothorax. But if there is an injury to the left side, beta, there can be left hemothorax, there can be injury to the spleen, there can be injury to the splenic flexure of colon, but hepatic flexure of colon is lying on the right side, so that is going to be least commonly affected. So I hope this was the catch out there. This question was just to apprise you that whenever we are solving the questions, we have to be very careful and we have to read everything, especially the last line of the question is very important. The art of solving the lengthy questions, read the last line of the question first. Okay? Then there was a question wherein appendicectomy was asked whether it's clean, contaminated or dirty. Now here in beta, if you have marked the answer wrong, that is not your mistake at this point of time, because we have not talked in detail about appendicectomy. We might be talking about this appendicectomy today late in the evening or maybe tomorrow morning. So I think let us wait till that time so that we really will come to know that if we have got partial information, then what can happen, but if we have complete information, then what can happen. So just hold on for this particular question. Let us do the appendicectomy story first, and then I don't think I will also need to discuss this question with you. Okay, you will get the answer once you know what is interval appendicectomy actually. Then there was a question which was related to the gold standard investigation in DVT. So let me also cross check whether we have written about that in the notes or not. Yeah, see beta. If you just a moment. If you just have a look here, gold standard investigation of veins, but not usually done, is a ascending venography, right? Though the investigation of choice is duplex imaging, but the gold standard investigation is ascending venography. So Shashank and so many other students, Vita, I hope you have got this. Now, let us move to our topic of discussion today. We were actually talking about the surgical chest pain stories. In this surgical chest pain story, beta, before we move forward, I think let us quickly revise the surgical chest pain, what we were talking day before yesterday evening, and I believe that you would have had some rest in terms of revision yesterday. So beta ji, let us quickly rewind that what actually is this surgical chest pain. Most often, beta, if we talk about chest pain, the first thought which comes to our mind is myocardial infarction. And that is something which is related to decreased blood supply by the coronaries to some part of the heart, right? And that causes infarction or maybe ischemic damage to some part of the heart muscle, because of which the heart muscles are not able to contract properly. That is a different story. Surgical chest pain we most often come across in GERD patients. GERD, beta, gastroesophageal reflux disease. Normally what happens in all of us, whatever you eat, that goes from mouth into esophagus and then into the stomach. This does not come back from the stomach into your esophagus, for the simple reason, beta, that God has given a nice integrity of your lower esophageal sphincter, so that does not allow the gastric contents to come back into the esophagus easily. Also, beta, if the stomach muscles are working nicely, they would be contracting properly. So whenever the food is broken down in the stomach and it becomes chyme, then the food travels from the stomach towards the duodenum. Also, the peristaltic movements in your esophagus, beta, they are moving from above downwards. So any movement which is going from above downwards in the esophagus will not easily allow the gastric contents to come up into the esophagus. Despite saying this, all of us who are watching right now, we all have got these transient lower esophageal sphincter relaxations, which may occur for 3 to 4% of times in 24 hours. And many of us would have definitely experienced, beta, that whenever we are taking some spicy food or something, sometimes like pani puri is a typical example, the golgappas, right? If suppose you are taking 15-20 pani puris or golgappas, then the golgappa water or the pani of the pani puri, that may come up from the stomach into your esophagus, and sometimes it comes into your mouth and you feel some bitter sensation in your mouth. Khatta khatta lagta hai muh ke andar, right? So what does this mean? This simply means that gastric contents are coming up. That means, are we suffering from a disease? The answer is no. This can be normal for 3 to 4% of times, and this would be commonly seen when the head would be in a down position. Right? So supine position, the chances of reflux are high. It is only when the frequency of these refluxes increase for more than 3 to 4% of times in 24 hours that we start labeling the person as having disease, and then we call it as gastroesophageal reflux disease. My dear friends, whenever this gastroesophageal reflux disease has to occur, then majority of the times it is the weakness of the lower esophageal sphincter. Who makes this lower esophageal sphincter weak? The most important culprit is smoking. The toxins in the smoke, the nicotine, that causes abnormal relaxation of the smooth muscles of lower esophageal sphincter, and that allows the gastric contents to come up into the esophagus. Not only smoking, beta, alcohol, chai, coffee, hot liquid, spicy food, obesity, progesterone, drugs like calcium channel blockers and nitrates, anything which relaxes the lower esophageal sphincter, this will promote GERD. And once this reflux occurs, the gastric acid comes up into the esophagus and patient feels a burning sensation behind the sternum, retrosternal pain or heartburn. Dil jalta hai. There would be chances of regurgitation. Patients also experience epigastric pain at times. How to approach this situation of epigastric pain? There is a standard protocol and standard guideline which we'll be talking about in detail in 45 minutes also. Any patient coming to us with epigastric pain, the first thought which comes to our mind is probably this is story of acid conditions. And we just want to reduce the acid secretion in these patients. So we want to modify the lifestyle of the person. If he's a type A personality, if he's an aggressive personality, if he takes a lot of tensions, anxiety and all that stuff, then the acid secretion would really be high. So you have to just calm down his nerves. Look, gentlemen, there's nothing which belongs to you on this earth. You know that you have come all alone on this earth, on this planet, and you'll be going all alone without taking anything from this planet except your good deeds. You will be remembered on this earth, on this planet for your good deeds, not for what you have earned or money or something in life, right? Okay. That means the person has to be counseled to reduce the anxiety levels, stop smoking, stop alcohol, stop chai, coffee, hot liquid, spicy food, reduce weight. Whenever the patient takes the meal, he should not sleep for 3 to 4 hours after meals, because till that time the food will be in the stomach and the intragastric pressure would be high. Whenever the patient is lying down on the bed, he is asked to elevate the head end of the bed by 5 to 8 inches. If the patient is able to follow this advice nicely, believe me, he will not have this disease. But this treatment looks to be a little expensive. If the patient can't afford, then we have to give him a wonder drug which can block the acid secretion, proton pump inhibitors. And my dear friends, my dear doctors, all acid related conditions, whether it is GERD or gastritis or peptic ulcers, the medical treatment of choice is PPI, and 90 to 95% patients respond to this PPI treatment. No investigation is needed. No surgery is needed in 90 to 95% of patients. This PPI is a wonder drug. But sometimes in those 5 to 10% of patients where the patient is either not taking PPIs properly or he is not responding nicely to PPIs, or even after taking PPIs he continues with his old lifestyle habits, then maybe he may not get complete relief in the symptoms and he may be coming again and again to you, doctor, please do something, I am having this epigastric pain. Now you are also getting confused. Okay, if PPIs are also not helping, let me find out what is the cause, why he is having this epigastric pain or retrosternal pain. So the first investigation what we do in these situations is upper GI endoscopy. On upper GI endoscopy, depending on where is the pathology. If you find something in the lower esophagus, you do something. If you find something inside the stomach, you do something. If you find something in the duodenum, you do something. If you find something in the lower esophagus, maybe red hot lower esophagus, and you suspect GERD, then maybe investigation of choice for GERD is upper GI endoscopy. But upper GI endoscopy cannot label that this is a disease. So to label that this is disease, you have to do a 24-hour study where you can demonstrate that, okay, the frequency of refluxes is more than 3 to 4% of times in 24 hours. So 24 hours pH monitoring. That is the gold standard investigation for GERD. We leave a pH monitor inside the esophagus. Normal pH in the esophagus is between 5 to 7. Stomach pH is strongly acidic, 1.5 to 2 or maybe 2 to 3. If the patient is having disease, this 1.5 to 2 or 2 to 3 pH will be coming into the esophagus for more than 3 to 4% of times, and you will find a drop in pH inside the esophagus below 4 for more than 3 to 4% of times. This is called as Johnson-de-Meester criteria, and that labels the disease. If the patient is suffering from this disease and medicines are not working, then we do a fundoplication. We just bring the fundus of the stomach, wrap it around the lower esophagus, so that now the chances of reflux are not there. Right. If when you're doing an endoscopy and you find some ulcer inside the stomach, look at me carefully, beta. If you find an ulcer inside the stomach, then stomach ulcers can become malignant. So we cannot take them lightly. During endoscopy only, you have to take a biopsy from the ulcer to rule out cancer. And also, beta G, these gastric ulcers and duodenal ulcers, the commonest culprit is the bacteria Helicobacter pylori. So it is our duty to find out whether H. pylori is present inside the stomach or not. And H. pylori lives in the pre-pyloric region, that is the antrum of the stomach. So we have to take a biopsy from the pre-pyloric or the antrum of the stomach. If H. pylori is found out, it is a bacteria, so we have to give a antibacterial treatment, eradication therapy comprising of 2 antibiotics and 1 PPI, right? Okay. If suppose on endoscopy you find a duodenal ulcer, then for duodenal ulcer, beta, they usually do not become malignant, so there is no point in taking a biopsy from the duodenal ulcer. But since H. pylori is the commonest culprit, so we should take a biopsy from the pre-pyloric or antrum to rule out H. pylori, right? Sometimes GERD can be associated with complications. Commonest complication is esophagitis. Itis is acute inflammation, rubor, tumor, calor, dolor, red, hot, lower esophagus. Whenever there is inflammation, there will be healing by fibrosis. Now, fibrosis contracts, and this can lead to narrowing of the lower esophagus. A stricture can develop in the lower esophagus. Because these fibroblasts contracts, the length of the esophagus may also shrink a little. That is called as shortening of esophagus. Another interesting complication is a Barrett's esophagus. Please remember, my dear doctors, Barrett's. This is something you not only read in surgery, but you also read in pathology. So, since Barrett's story is quite interesting, on 17th of December, if the examiner asks you what is the commonest complication of GERD, please do not mark Barrett's. The commonest complication of GERD is esophagitis, right? Barrett's can occur, and Barrett's is basically when the lower esophageal squamous mucosa is continuously facing the acid damage. Then the lower esophageal squamous mucosa gets irritated and it starts praying to God. God, please see what is there inside the stomach. There is so much of acid in the stomach. But despite so much of acid in the stomach, see, the stomach mucosa is normal. There is no problem. Then God tells the lower esophageal squamous mucosa, look, I have given a mucus barrier in the stomach. Goblet cells, they are secreting mucus, so they form a coating of mucus on the surface of the stomach. That is why the acid does not come in contact with the gastric mucosa, and the gastric mucosa is living happily. So the lower esophageal squamous mucosa also prays to God, God, please give me those goblet cells so that I can also develop that mucus barrier. And God gifts this mucus barrier to the lower esophageal squamous mucosa. For that, The lower esophageal squamous mucosa undergoes intestinal metaplasia. If you look at the goblet cells, they are much more abundant in the intestine as compared to stomach. So lower esophageal squamous mucosa wanted a protection. So this lower esophageal squamous mucosa converts into columnar, that too intestinal type of columnar, so that more amount of goblet cells are there, and when they secrete mucus, then a mucus barrier is formed in the lower esophagus, and now whatever acid is refluxing, that is not going to damage the lower esophageal mucosa easily. This is the story of Barrett's. Hallmark of Barrett's: goblet cells. The squamocolumnar junction move upwards. We have to do an endoscopy and take a biopsy from the lower esophagus, and on biopsy, if you find goblet cell in the esophagus, then it is diagnostic of Barrett's, because goblet cells otherwise are absent in the esophagus. Okay, once the diagnosis is made, then we know that this Barrett's esophagus has a very high risk of converting into cancer. This is a columnar mucosa, so adenocarcinoma can develop in this lower esophagus now in Barrett's. So we cannot take any chances, and we want to destroy the lower esophageal mucosa by any modality. Maybe by laser, photocoagulation, argon beam coagulation, or endoscopic mucosal resection can be done. Plus, PPIs have to be given. Another complication of GRD is hiatus hernia. Hiatus hernia. Hiatus means the opening in the diaphragm. God has given 3 openings in the diaphragm, which are remembered by the mnemonic Voice of America. VOA. V, vena cava. O, esophagus. A, aorta. Vertebral levels T8, T10, T12. This is what we read in anatomy class. Okay. The 3 openings in the diaphragm: Voice of America. VOA. Vena cava, esophagus, aorta. Vertebral levels T8, T10, T12. That means esophagus passes through the diaphragm at the T10 vertebral level. That is the opening for esophagus in the diaphragm. Sometimes what can happen, beta? If the stomach, which lies in the abdomen, goes through this hiatus into the thorax, then we call it as hiatus hernia. And in GRD patients, because of continuous reflux, the stomach starts pushing the esophagus up. And that is how the gastroesophageal junction moves up into the thorax. This is called as a sliding hiatus hernia. There is another type of hiatus hernia which is not related to GRD, but just to differentiate the 2 types, we discuss that type here. That is a paraesophageal or a giant or a rolling hiatus hernia. In that hernia, there is a weakness in the diaphragm, and through that weakness in the diaphragm, the fundus of the stomach moves up into the thorax. The gastroesophageal junction remains within the abdomen. So we are discussing here 2 types of hiatus hernias: sliding and paraesophageal. There can be a mixed variety also, but sliding is much more common than paraesophageal. Sliding is associated with reflux, but paraesophageal is not associated with reflux. The chances of complications are more in paraesophageal. To know whether the stomach is in the thorax, you can simply take a photo of the chest. Not the selfie photo, beta, but a chest X-ray. And on chest X-ray, you will see the stomach in the thorax, right? Now, whether it is a sliding or paraesophageal, I cannot make out on X-ray, because on X-ray, I am not able to see where is the gastroesophageal junction. If I have to see whether the gastroesophageal junction is in the thorax or in the abdomen, then I have to give a contrast. So earlier we were doing a barium meal for the stomach. But now we are doing a CT scan with contrast. And that contrast can show us whether the G junction is in the thorax or the abdomen, and we can differentiate whether it is a sliding hernia or a paraesophageal hiatus hernia. Once the diagnosis is made, we follow the same concept in the treatment of all hernias in the body. जो अपना घर छोड़ के चला गया है उसके कान पकड़े जाएं, उसको वापस घर के अंदर डाला जाए और फिर ऐसा ताला लगाया जाए कि दोबारा घर छोड़ने की गलती ना करे. The basic concept in the treatment of hernias, if somebody has left his home, we have to just hold on to his ears, put that person back into his home, and then create such barrier so that this person will never try to come out again. Right. So in hiatus hernia also, if the stomach has gone into the thorax, we do a surgery, we bring the stomach back into the abdomen and then wrap the fundus of the stomach with the lower esophagus so that now the stomach will not be able to go into the thorax. That is fundoplication. Right, beta? So I hope you were able to understand these concepts nicely. ठीक है, अब आगे चलते हैं. Now just give me a moment. I'm so sorry. I'm so sorry. Uh, I was muted. Got it, beta. Got it. Got it. Okay, beta. Thank you so much, Viral. I'm really very sorry. I did not see that, and I was just muted. Okay. I'm sorry. My mistake. It was my mistake. Okay. Thank you so much. Right. So let's start the story once from the beginning, beta. See, we are just trying to discuss a Bohr-Havi syndrome. That is a barotrauma. Baro means pressure. That means this Bohr-Havi would be related to pressure-related trauma. Now, what happens, beta? As we grow older and older, the tissues become weaker and weaker. जैसे जैसे उम्र बढ़ती है, इमारतें कमजोर होती है ना. So, what can happen? Sometimes, if suppose Friday night, Saturday night, 60, 70, 80-year-old gentleman, he goes to a party. And in that party, suppose he takes 4 bottle vodka. Now that 4 bottle vodka, binge drinking, heavy drinking, that vodka is going to irritate the stomach, right? So that vodka is going to irritate the stomach. And suppose in that party he takes huge amount of meal, maybe he takes a lot of mutton biryani, chicken biryani, or maybe a lot of chapatis, butter paneer, and all that stuff. So what is happening inside the stomach? The stomach is getting confused. Oh my God, why so many people are coming into me? 4 bottle vodka, mutton biryani, chicken biryani, everything. Now the stomach is getting full, and maybe the pressure inside the stomach is increasing. And sometimes when there is a high pressure inside the stomach muscles will try to throw everyone out. We know that the normal exit from the stomach is towards the duodenum through the pylorus, right? But if the stomach muscles are contracting forcefully, then because of this high pressure, this 4 bottle vodka, mutton biryani, everything will come up towards the esophagus. And beta, if you carefully take a look at this part of the esophagus, which is very close to the stomach, this is considered as the weakest part of esophagus. Okay, so if there is a high pressure, this high pressure can cause rupture of the esophagus. As soon as the esophagus ruptures, all this 4 bottle vodka, chicken biryani, mutton biryani will leak into the mediastinum under pressure. And there will be huge amount of this 4 bottle vodka and mutton biryani in the mediastinum, right? Now just imagine chicken biryani in the mediastinum. The mediastinum will get confused. Oh my God, what is this? And then party can start in the mediastinum. Patient will present with severe pain in the left side of chest, sometimes radiating to the left shoulder and maybe to the left arm, just mimicking the presentation of acute myocardial infarction, just mimicking heart attack type of situation. Now, since this is a case where there is huge amount of bacterial party which may start in this area, right? So, we need to understand the basic pathology. The patient, just imagine, coming to you with left-sided chest pain in emergency, right? Herein, the first thought which will come to your mind is this would be a heart attack. So immediately you will be doing some ECG and cardiac enzymes. But when you look at that, oh, everything is normal. ECG is normal. Cardiac enzymes are normal. Then we know that in Bohr-Havi syndrome, when there is huge amount of leakage into the mediastinum, it is not only the vodka or just the chicken biryani or mutton biryani which has leaked, but whatever air was present here in the stomach, that would also have leaked into the mediastinum, which we call as pneumomediastinum. पूरे mediastinum में बेटा हवा भर गई है. And now this air may also seep through the layers of the chest wall and come to lie beneath the skin. जो हवा stomach से निकली, that हवा in the mediastinum, now it is coming beneath the skin also. That is called as subcutaneous emphysema. Subcutaneous, beneath the skin, emphysema related to air. Okay, this is also called as surgical emphysema. right? We can just say that this is something which is pathognomic of Boer-Havi syndrome. There is a triad actually, which is vomiting, chest pain, and subcutaneous emphysema. I repeat, beta, vomiting, chest pain, and subcutaneous emphysema. This is called as Mackler's triad. When you are examining these patients, na beta, because of air beneath the skin, when you hear with the stethoscope, you hear sounds of air beneath the skin, cud, 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 cud type of sounds, as if somebody is walking on the snow, footsteps on the snow. जैसे बर्फ पे चलने की आवाज होती है ना, जूते लेके जब आप बर्फ पे चलते, तो that creates some sound, right? You must have, you would have experienced that. Many of you would have experienced that, and some of you, if you have not experienced that, you might have seen in the movies or here and there when somebody is walking in the snow, there's a typical sound. The same type of sound is what you can hear on auscultation if there is subcutaneous emphysema. This is called as Hammond's sign, Hammond's crunch, mediastinal crunch, right? Now, you are suspecting कि boss, there is no cardiac event, so it can be a case of rupture esophagus. And now, what I can do is I can take a chest X-ray quickly. If I just take a chest X-ray, I can find free air in the mediastinum, pneumomediastinum. But if I want to see whether it's a esophageal perforation or not, I think I should do a CT scan. So you can quickly take a CT scan. You can even give the contrast in the esophagus. Now suppose beta, when you're doing a CT scan here, right? What has happened actually, all this chicken biryani, mutton biryani is actually lying in the mediastinum. There is huge amount of air in the mediastinum. Suppose you are giving contrast in the esophagus, you are doing a contrast study. See, CT scan contrast. The contrast is coming into the esophagus, Ab kya hoga beta? What will happen here? What will happen here? The contrast will be going down below also, plus there will be leakage of contrast into the mediastinum also. So you will find this contrast in the mediastinum. And this contrast beta will be able to show you the exact site of perforation as well as the size of perforation. So CT scan with contrast will give us the perfect diagnosis that this is a case of esophageal rupture. Now, how to manage this situation beta? We know that if there is mutton biryani, chicken biryani, vodka in the mediastinum, there is high risk of bacterial party in the mediastinum. If bacterial multiplication is going on, patient may go into septicemia. And septicemia means what? Huge amount of bacteria in the blood. They might be going to all places in the body, and septicemia can even lead to death of this person. You are the doctor boss. You have to save the life of this patient. Oh my God, what has happened? Just because of leakage of vodka and chicken biryani in the mediastinum, patient is taking the flight, patient is dying. Why? Because there is a bacterial party which has now spread into the blood. Bacteria may be going to all parts of the body. Patient can die because of high amount of infection. So what we need to do to save the life? We need to reduce the septic load. Whatever infection is present here, we need to quickly reduce that septic load. Now we know that to destroy the bacteria, we have to give IV antibiotics. Yes, we give the IV antibiotics. But here we are talking about a huge amount of bacterial load. By giving a IV antibiotic, this much of antibiotic may not be sufficient to kill these many bacteria. Here, the major source is this mediastinum. So to save the life of this patient beta, you have to remove this party. And for that, you can just do a thoracotomy. Open the thorax, go inside the mediastinum and do a nice thoracic lavage. अच्छे से झाड़ू पोछा लगाएंगे बेटा. Modi ji Swachh Bharat Abhiyan. You just clean this mediastinum nicely, do a nice thoracic lavage, and that will remove the septic load, and that will be able to save the life of this patient. Just imagine February 23 beta. Right? In February 23, just imagine yourself in the operation theater. Just imagine a knife in your, not the knife, the scalpel in your hand. You are doing a thoracotomy. And now you see a lot of chicken biryani in the mediastinum. You have used a huge amount of normal saline from outside and you are just cleaning all the mediastinum nicely. Once all that septic content is removed, now there's a clear picture in front of you. क्या किया बेटा अपन ने thorax को खोला है. You have just made us incision in the thorax, suppose. And now all the thorax, this whole story is right in front of you. Here there was huge amount of chicken biryani, vodka and everything and the bacterial party. So you have just removed all this bacterial party, right? Now everything has become clean in this area. You look at the perforation and the perforation looks at you. Now what should be done? Whether we should close this perforation or not. If there is huge amount of bacterial party which has taken place here, if there is huge amount of bacterial party, then we cannot close this perforation beta. दोबारा से ध्यान से सुनिएगा. Look at me on the screen, listen carefully. If there is huge amount of contamination in this area, if there is a huge bacterial party in this area, there is high amount of infection here. And if you try to suture this perforation, the bacteria will eat up the sutures. So the very purpose of putting sutures in this area will be defeated because bacteria will eat up the sutures. I repeat this in Hindi beta. हमने क्या किया इस पेशेंट में, ये पेशेंट की जान जा रही थी. क्यों जा रही थी? क्योंकि बहुत सारे बैक्टीरिया की पार्टी चल रही थी. हमें उस बैक्टीरिया के लोड को कम करना था. हमने आईवी एंटीबायोटिक्स तो दे दिए, लेकिन उससे ये इतना बड़ा लोड कम नहीं होता. तो हमने थॉरेक्स को खोला, थॉरेकॉटमी की, अंदर गए और अच्छे से झाड़ू पोछा लगाया. नॉर्मल सलाइन से अच्छे से धुलाई सफाई की. उस धुलाई सफाई से सारा कचरा साफ हो गया, बैक्टीरिया का लोड कम हो गया, पेशेंट की जान बच गई. अब जब ये सारा हिस्सा साफ हो गया तो ये जो परफोरेशन है ना बेटा, ये आपको आशा भरी निगाहों से देख रहा है कि भैया मेरा भी तो कुछ करो. अब समस्या ये है कि अगर इन्फेक्शन बहुत ज़्यादा है और हम यहाँ पे टाँके लगाएंगे तो ये जो बैक्टीरिया है ना, ये उन टाँकों को खा जाता है. यानी कि conceptually if you try to understand beta, listen carefully. This is an important concept which is applicable in all 19 subjects. Whether it is OBG or ENT or ophthalmology or surgery or any surgical branch. Whenever there is a high amount of infection, whenever there is gross contamination, we do not put the sutures. Otherwise, the bacteria will eat up the sutures. Plus, we might be trapping the infection there itself. कुत्ता काटता है तो हम उसको टाँके लगा के बंद करते हैं क्या? In a dog bite, do we close that dog bite wound? नहीं ना. If you close the dog bite wound, what will happen? The bacteria will be trapped inside. And then the bacteria will be going into the deeper layers and that will spread the infection because the dogs, they have got huge amount of anaerobes inside. So the chances of infection are very high, right? Okay, right. So if there is gross contamination, then we do not close this perforation. We leave it open. But we have to close the thorax. ऐसा तो नहीं है बेटा कि थॉरेक्स को भी खुला छोड़ के और पेशेंट को ओटी से बाहर निकाल दें. वी कैनॉट जस्ट लीव द थॉरेक्स ओपन एंड डिस्चार्ज द पेशेंट विद ओपन थॉरेक्स. सो वी हैव टू क्लोज द थॉरेक्स, बट वी आर नॉट क्लोजिंग द परफोरेशन. द रिस्क इज whatever contents, whatever gastric juices would be here, or if the patient is allowed to take something, some meals, obviously that is going to come again out in this area through the perforation. So what we can do is, we can just leave a tube drain here. We can just leave a tube drain here so that if there is any content which leaks, here, that should not remain here. That should actually come out through this drain tube. So if that is coming out through the drain tube, then the chances of septicemia would not be there. Okay, so I repeat this story, beta. In Bohr-Havi syndrome, to save the life of the patient, we are doing a thoracotomy. We are doing a nice mediastinal lavage. That saves the life. Whether to close the perforation or not, that depends on the amount of contamination. If the amount of contamination is more, we cannot close the perforation. We just leave a drain tube near the perforation so that whatever leaks from the perforation, that comes into the drain tube and that goes outside the body. That contamination should not remain inside the body, right? Once the story settles, then maybe after 6 weeks, 8 weeks, 12 weeks, we can think of closing this esophageal perforation later on, right? But not at this stage. However, beta, if by chance, suppose the contamination is less, that there's not much contamination, you have done a thoracotomy, you have done a cleaning and everything. If the contamination was less, you have done the lavage, and now you feel that yes, since the infection is less, you can close the perforation. So in that case, if the infection is less, then yes, you can just put the sutures on this perforation, right? That is the whole concept. Now let's take a look. What all is written here, beta? In the surgical chest pain or Bohr-Havi syndrome, which is also called as barotrauma, there is a spontaneous esophageal perforation. As you are seeing, beta, again and again, all these images, we are focusing on this particular area, right? Okay. This is the spontaneous esophageal perforation. Spontaneous means apne aap, on its own. It is transmural. Transmural means all layers. Obviously, in a perforation, all layers are going to get involved, like mucosa, submucosa, and muscle. All layers involved. तभी तो perforation बोल रहे हैं. Mucosa, submucosa, muscle, सब फट गया है. That is what is transmural. This is seen in the lower esophagus, commonly seen in elderly people. After heavy meals. And binge drinking. Beta, there are two MCQs for which the examiner is using the term binge drinking. Binge drinking का मतलब होता है एक बार में ज्यादा पीना, एक बार में 4 बोतल वोडका पीना. I'm just joking, not 4 bottle exactly, but yes, huge amount of drinking at one point of time. After heavy meals or binge drinking, the intragastric pressure will be high. High intragastric pressure that will cause forceful vomiting, and because of this forceful vomiting, the esophagus ruptures. Because of this forceful vomiting, beta, the esophagus ruptures at the weakest point. Esophagus ruptures at the weakest point. Most common site of esophageal rupture, it is the left lower esophagus in the posterolateral wall. So what happens as soon as this esophagus ruptures? All the gastric contents are released into the mediastinum under high pressure. This leads to severe mediastinitis where there is risk of septicemia. How the patient is going to present to you? There will be sudden, severe left-sided chest pain radiating to the left shoulder and to the left arm. This mimics myocardial infarction. इट मिमिक्स मायोकार्डियल इन्फार्क्शन, जैसे हार्ट अटैक का प्रेजेंटेशन होता है ना, वैसा ही लगता है एकदम, just like the presentation of heart attack. Apart from the left-sided chest pain, beta, lot of air has leaked into the mediastinum, and this air seeps through the layers of the chest wall and comes to lie beneath the skin. That is called as subcutaneous emphysema. Subcutaneous emphysema, and this is considered pathognomic of Bohr-Havi syndrome. This subcutaneous emphysema, beta, this is also called as surgical emphysema. Any condition where there will be collection of air beneath the skin, air beneath the skin of the chest wall. Or not specifically chest wall, just air beneath the skin is subcutaneous emphysema. We can find this in the abdomen also. Mechler's triad. Now this Mechler's triad, beta, as we were talking about, this is a combination of vomiting, chest pain, and subcutaneous emphysema. Subcutaneous emphysema. 4 बॉटल वोडका पिया, उसके बाद इंट्रागैस्ट्रिक प्रेशर बढ़ा, जोरों से वॉमिटिंग हुई, वॉमिटिंग में ईसोफेगस रप्चर हुआ और स्टमक का सामान लेफ्ट साइड मीडियास्टिनम में गया, क्योंकि लेफ्ट साइड पे रप्चर ज्यादा कॉमन है, उससे पेशेंट को चेस्ट पेन हुआ और सबक्यूटेनियस एम्फाइसेमा हुआ. सो बेसिकली हाउ टू अप्रोच दीज पेशेंट्स इन इमरजेंसी सिचुएशन. Since we know there is septicemia, so there are chances that patient can even die. The first and foremost thing as a doctor, what we know, the first lesson what we learn is to save the life. And to save the life, we do a basic resuscitation. We quickly rule out any cardiac event. For this, beta, you can quickly do ECG and you can get the cardiac enzymes done. Everything would be normal if you are dealing with a Bohr-Havi syndrome. Once the patient is stabilized, you do the auscultation, and on auscultation, whenever there is air beneath the skin, wherever in the body, you will hear sounds as if somebody is walking on the snow, footsteps on the snow. This is called as Hammond's sign. Hammond's sign. Hammond's sign or Hammond's crunch. This is also called as mediastinal crunch. Mediastinal crunch. Just to remind you, beta, that Homans and Moses sign. Homans sign was resistance to dorsiflexion of foot, and Moses was calf pain on squeezing the calf muscles. They are seen in deep vein thrombosis. Deep vein thrombosis. And please be careful about this. This Homans is seen in DVT, while Hammond's is seen in Bohr-Havi syndrome. Right. Now, first investigation, beta, what we can do is a chest X-ray. We can do a chest X-ray, CXR, chest X-ray. And here you will see free air in the mediastinum, which we call as pneumomediastinum. Pneumomediastinum. Best investigation, beta, CT scan with oral contrast. If oral contrast has to be used, then generally we keep on talking about barium, 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 barium everywhere. Look at me on the screen, beta. In GI perforations, whether it is esophagus, stomach, duodenum, jejunum, ileum, colon, in GI perforations, if we use barium as contrast, then barium will leak out from the perforation, like esophageal perforation, and you are giving barium, this barium will leak outside. Barium is hypertonic. and this causes significant injury to the surrounding structures. The same story in abdomen. If it is a gastric perforation or a colonic perforation and you are using barium as the contrast, barium will leak from the stomach or the colon into the peritoneal cavity and will cause significant injury in the peritoneal cavity. So whenever you are suspecting GI perforation, please do not use barium. There are less injurious contrasts like gastrographin, which are water soluble, which causes less injury. So whenever GI perforation is talked about, we don't use barium as the contrast in contrast studies. If oral contrast has to be used, gastrographin is preferred. Gastrographin is preferred. It is water soluble and less injurious. It is water soluble and less injurious. You can just make a note here. Barium is hypertonic. Not used in GI perforation. Not used in GI perforation. Right. If we take a look at this image beta, this is a contrast study what you're seeing here, which is there in your workbook. If we try to give the contrast, you're seeing that contrast is coming into the esophagus. This is the stomach. If there is a perforation, then the contrast will leak through the perforation and this contrast will leak into the mediastinum, right? The treatment for these Bohr-Havi syndromes, beta, we have to open the thorax, go inside and save the life of this person. Most important in saving the life of this person is mediastinal lavage. Mediastinal lavage is going to be life-saving. Jhadu pocha lagana. If it is a thoracic story, mediastinitis septicemia, thoracic lavage. If it is a abdominal story, peritonitis septicemia, do a peritoneal lavage by opening the abdomen, right? Okay. This is the general statement. Now, when you have done a mediastinal lavage, then closure, non-closure of the perforation will depend on the amount of contamination. If suppose the contamination is less, that means if the patient presents to you early, before 4 to 6 hours only after perforation, then beta we can close the perforation, closure of perforation. And this is the concept which you apply in the abdomen also. Suppose we talk about gastric perforation, colonic perforation, then the inside masala leaks into the peritoneal cavity which can cause peritonitis and septicemia. So there also what we have to do, laparotomy, peritoneal lavage, that will save the life of the patient. Whether to close these gastric or colonic perforations or not simply depends on the amount of contamination. If the amount of contamination is less, you can close the perforation. But if the patient comes to you late, where there is cross contamination or cross infection, then we cannot close the perforation. Then we cannot close the perforation. In these situations, we just leave a drain. And then we can decide later what has to be done, maybe after 6 weeks, 8 weeks, or 12 weeks. Right, Ji. So this was about the Bohr-Harvey syndrome story. Since we talked about a spontaneous esophageal perforation, it is our duty beta to talk about the commonest esophageal perforation. Commonest. Bohr-Harvey syndrome is not the commonest esophageal perforation. February 23, when you'll be working in the hospitals, beta, you would be seeing the endoscopic procedures quite often. Just imagine that your boss or your surgeon is trying to put the endoscope inside. Now, if you look that the endoscope has to pass from the mouth, then the pharynx, then the esophagus, then in the stomach, and then in the duodenum. In this entire tract, the cricopharyngeal sphincter is the tightest area, the narrowest area. So sometimes what happens when the surgeon is passing or the endoscopist is passing the endoscope, if suppose suddenly the surgeon's focus shift toward the staph nurse, suppose a beautiful staph nurse comes from around and the surgeon is passing the endoscope, suddenly the focus shifts, the endoscope can shift. It is the cricopharyngeal sphincter where the endoscopist has to be very careful, because that is the tightest area which will offer maximum resistance. So many times there is a possibility that just proximal to the cricopharyngeal sphincter, the esophagus can rupture during endoscopy. This rupture is because of the staph nurse. No, this rupture is because of the surgeon, right? So anything which is doctor induced, we use the term iatrogenic. क्या बोलते बेटा? Doctor induced iatrogenic. So this is a iatrogenic esophageal perforation, and we all can understand that nowadays endoscopies are done so frequently. So obviously the chances of endoscopic esophageal perforation will be much more as compared to Bohr-Harvey syndrome. So commonest esophageal perforation is a iatrogenic doctor induced on endoscopy. There are two types of endoscopes, which are rigid and flexible. Nowadays we are not using rigid, we are using flexible. What is the difference? Rigid means rigid. Rigid is just like a danda, the pencil what you're seeing here, right? So this is a rigid, you cannot bend it. But a flexible is flexible. Rigid is somewhat like this, beta, like a pen which you are holding. You cannot bend your pen. But flexible would be flexible. Flexible is just like a wire, right? So you can flex it easily. So which will cause less injury? The rigid endoscope or the flexible endoscope? Obviously the flexible endoscope will cause less injury. So the chances of esophageal perforation are more with a rigid endoscope or flexible. Perforation more with rigid, right? But generally what happens, beta, just imagine that endoscopy room where the endoscopist is passing the endoscope, staff nurse, focus shift, endoscope shift. Generally endoscopies, beta, they are done when the patient is conscious, right? So many a times what happens, the patient is lying in the left lateral decubitus position and the patient is also looking at the monitor, and he is able to see when the endoscope is going inside. Surgeon is also looking at the monitor and the patient is also looking at the monitor. Till the time the endoscope was going into the esophagus, the patient was not enjoying, but as soon as the esophagus ruptures and the endoscope goes into the mediastinum, suddenly the heart is beating on the monitor. The patient can see, now I am enjoying, my heart is beating. But suddenly the surgeon's heart starts beating faster and faster. Oh my God, what have I done? And then he starts cursing the staff nurse. Why did you come at this point of time when I was at the cricopharynx? Now what should be done? The options can be, should the surgeon continue now esophagoscopy as mediastinoscopy and say hello to different mediastinal structures? Should he take the endoscope out and leave it like that? Should he take the endoscope out, do a thoracotomy and close the esophageal perforation? Now, what we have seen over a period of time is that these iatrogenic esophageal perforations, they heal spontaneously. They do not require any operative closure. So there is no need to do a thoracotomy even after a iatrogenic esophageal perforation. We just remove the endoscope, put a nasogastric tube, that is tube from the nose into the stomach, so that nothing leaks from that perforation into the mediastinum. Obviously, beta, these endoscopies are done when the patient is kept empty stomach for some time. So there is nothing inside the esophagus. There are no secretions inside the esophagus. Even if the saliva is coming down, since there is a nasogastric tube, so the chances of saliva leaking into the mediastinum are also less. That means iatrogenic esophageal perforations do not carry the risk of any septicemia or any mediastinitis type of story. No chest pain, nothing. Just put a nasogastric tube, leave it there for 5 to 7 days. These iatrogenic perforations will heal spontaneously without any intervention. That means treatment is conservative, non-operative for iatrogenic perforations, right? Look at me on the screen. Iatrogenic perforations are in the upper esophagus. Boerhaave is in the lower esophagus. Iatrogenic perforations, no surgery is required, just a nasogastric tube. But Boerhaave syndrome, you had to do a thoracotomy, you had to do a mediastinal lavage, and then you had to decide whether to close or not to close the perforation, right? So Boerhaave, the treatment is operative, but iatrogenic, non-operative, right? Okay. Now let's see beta what is written here. If we take a look, surgical chest pain, iatrogenic esophageal perforation, most common cause. Most common cause of esophageal perforation is iatrogenic. Iatrogenic is doctor induced. And how iatrogenic? It is due to upper GI endoscopy, upper gastrointestinal endoscopy. Now, which endoscope, beta? Rigid endoscope. Rigid endoscope will have more chances of injury than flexible endoscope. Rigid endoscope will have more chances of injury than flexible endoscope. Most common site of these iatrogenic perforations, that will be near the tightest area, that means above the cricopharynx, or you can just write near the cricopharynx. Near the cricopharynx. Also beta, please remember that iatrogenic perforations are much more common than Boerhaave syndrome. Treatment for these iatrogenic perforation, it is non-operative. That means conservative treatment. Just leave a nasogastric tube for 5 to 7 days and these iatrogenic perforations will heal spontaneously. अपने आप ठीक हो जाएंगे. Okay? So just to remind you once again beta, that suppose I say this is the esophagus, this is the stomach. The commonest esophageal perforation is iatrogenic, and this is near the cricopharynx. So this is the most common. And no operative intervention is required here. A less common esophageal perforation is Boerhaave syndrome. This is spontaneous, अपने आप होता है. It is not doctor induced, right? It is in the lower esophagus and the treatment for this will be operative. You have to do a thoracotomy, mediastinal lavage, and then whether to close or not to close the perforation, the decision depends. ठीक है बेटा, confusion तो नहीं होगा इसमें. What is the most common, upper esophageal perforation or lower esophageal perforation? So upper esophageal perforation near the cricopharynx. So why this occurs? Doctor-induced endoscopy. Which endoscope? Rigid endoscope. Do we need to do any operation, any thoracotomy to close this perforation? Generally, no. We just leave a nasogastric tube. Just leave a nasogastric tube like this, so that there is nothing which can leak out, right? Okay, beta. चलिए जी. Now, another thing related to surgical chest pain is regarding the foreign bodies in the esophagus. This is also quite interesting, beta. We can find different foreign bodies inside the esophagus, and there have been a lot of questions available on different platforms related to this. Now, this image, beta, what we are seeing, this is a coin. Now, whether this coin is in the trachea or the esophagus, we don't know. Just to simplify this, beta, though your ENT sir will be taking this in detail, but let us just try to understand. If I say this is the trachea, and on this side, if I say this is the esophagus. So, in the trachea, beta, there is larynx above. So, because of the larynx, because of the vocal cords, what happens? Suppose the vocal cords, the upper part is the larynx, right? So there will be vocal cords here. And suppose a coin is going down. Now, when the coin is going down through the trachea, then the coin, because of the vocal cords, circularly it cannot go down. So it becomes linear. That means the coin actually becomes somewhat like this. If it is in the esophagus, then the coin in the esophagus, if the coin is in the trachea, because of the vocal cords, the coin cannot go down circularly, but the coin has to become like this. So it goes down like this. While in the esophagus, there is no vocal cord or something. So the coin which is coming down, that would be coming like this. That means when you are taking a X-ray from the front, right? X-ray from the front. Suppose I say, beta, that this what I'm having is a coin. Okay, suppose this what I'm having is a coin. Now, if this coin is coming from the trachea, what is going to happen? This coin, because of the vocal cords, this coin will become somewhat like this. Now just look here, beta. When this is coming into the trachea, right? Because of the vocal cords, it will become like this. So when you are taking a X-ray from the front, the coin will appear like this. Okay? When you are taking a X-ray from the front, if it is in the trachea, it will appear like this. But if it is in the esophagus, the coin will be coming like this, and on the X-ray, the coin will appear like this, a circular shadow. Okay, so here in this X-ray, beta, you see a circular shadow. So this coin is in the esophagus. Now, if I say, beta, that we are not taking the X-ray from the front, but we are taking the X-ray from the side. That means if I stand like this, okay, just imagine. If the coin is in the trachea, then it is lying somewhat like this. Okay. When you are taking the photo from the front, the coin is appearing like this. Coin in the trachea is appearing like this when you are taking the X-ray from the front. But if you take the X-ray from the side, then from the side, beta, this is what you are going to see. So from the side X-ray, the coin in the trachea will appear as a circular shadow, right? If you look at the esophagus, the coin is coming like this. So when you take a X-ray from the front, it appears as a circular shadow. But if you take a X-ray from the side, then only this border of the coin is seen. So here you will see a linear shadow only. That means if you see a linear shadow on a lateral X-ray, then it is a coin in the esophagus. Basically, what we have to do is we have to just remember one thing. कोई भी एक चीज याद कर सकते हैं अपन कि if the coin is in the esophagus, then on the front view the coin will appear as a circular shadow. That's it. Rest everything you just forget. Now, if on a front X-ray the coin appears circular in esophagus, so on a lateral X-ray it will appear linear, and just the opposite will be the trachea. So coin appears like a laddu on a front X-ray if it is in the esophagus. However, when you'll be seeing more X-rays during the course of time, during these missed classes, you will be coming to know more about this. Let us just try to imagine the different scenarios. These images, what you're seeing, this is the open safety pin inside the esophagus. This is the denture, what you are seeing inside. This is the denture, the artificial teeth. Some elderly person, maybe he would have taken some hard guava along with the denture. So maybe when he was biting that hard guava, the guava along with the denture might have gone inside the esophagus. We do understand, beta, that small babies, they have a habit of swallowing whatever comes on their way. So if suppose there's a small baby who is swallowing this coin, घर में कई बार ऐसे सिक्के पड़े होते हैं ना loose, and these babies, they are fond of swallowing these coins. Now what actually happens? Majority of time what happens, beta, this coin what you're seeing, baby swallows the coin, it negotiates the cricopharynx, and if it negotiates the cricopharynx, then it is not going to get obstructed usually in any other part of the intestine. So एक बार अगर सिक्का मुंह से गया और क्रिकोफेरिंक्स से नीचे उतर गया, फिर ये जीआईटी में कहीं भी ऑब्स्ट्रक्ट होने के चांसेस इसके काफी कम होते हैं. So majority of times when the baby swallows the coin, if it is going into the esophagus, crosses the cricopharynx, then this coin is going to pass as such out, and many times nobody will ever come to know whether the baby swallowed the coin or not, right? This is the usual story. Sometimes the baby has swallowed the coin and the mother comes to know about it, and then the mother may start scolding the baby. Why did you do that? Why did you do that? And then the mother would be coming to you in the hospital in a panicky type of situation. Doctor, 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 my child has taken 2 rupee coin inside. And many times what happens, beta, you look at the child. Ha, beta, the child looks at you. Ha, doctor. You find that everything is comfortable, right? The baby is absolutely fine. The baby is absolutely comfortable. Now, in these scenarios, what should be done? Should we open the thorax of this baby, or should we do a laparotomy for this baby to take the coin out? No. If the baby is absolutely comfortable, no intervention is required. Just counsel the baby, just counsel the mother that don't worry, this coin will pass out on its own, right? You can just come to us after 3 to 4 days, and we'll have a check if there is anything we feel. Or if the baby develop any particular symptoms, then please do report in the emergency. So majority of the times nothing is needed. There are things which keep on going on here and there, that we should encourage the babies to take banana mesh. Banana. Now yes, banana mesh that actually creates some jelly-like consistency in the intestine, and if there is a coin in the intestine, then coin get mixed with the jelly-like consistency of the banana, and that may facilitate the passage of coin easily without causing injury to the mucosa of the intestine. Okay. Sometimes there may be rare situations, baby has taken the coin and the coin gets stuck at the cricopharynx. If the coin gets stuck at the cricopharynx, then the baby might have difficulty, maybe some choking type of sensation is there. In these cases, the best thing is you put the endoscope and take the coin out. Immediate endoscopic removal for esophageal foreign bodies is the answer. Many times, if there is a foreign body in the trachea, then the baby might have that breathing issue. The baby might not be able to breathe properly. In those cases, beta, we can try doing a Heimlich's maneuver. Heimlich's maneuver is compression of the lower sternum. This lower sternum, you just compress the lower sternum so that the baby can throw the coin out. That is recommended if the foreign bodies are in the larynx, trachea, tracheal foreign bodies, right? Okay. So here in beta, this what we are seeing, this is the image of the coin, this is the safety pin, and this is our denture, artificial teeth. Most common foreign body in a child is a coin. In an adult, it is the food material. Like commonly you might have heard about fish bone getting stuck. Elderly people, it is the denture, that is the artificial teeth, or maybe even the loose teeth. If the patient does not have any symptoms, no treatment. If the patient develops symptoms, choking type of thing, then endoscopic removal. One thing which we can try beta, if food bolus gets impacted, in the esophagus, then we give fizzy drinks. Fizzy drinks like colas, sodas, which creates that fizz. Now, what is the advantage of that fizz? Basically, gas is there, right? So, if suppose a food bolus is impacted here, and you give those drinks which created gas, so because of that gas, the food bolus might disintegrate, and if the food bolus disintegrates, then it will be able to pass down easily, right? Okay, beta. If there are batteries inside, then yes, we cannot leave the batteries inside, especially if they're expired batteries, we have to do immediate removals, right? Okay, so this is the overlapping topic which will be discussed in a little more detail in your ENT classes as well, right? So this is a story about the chest pain. What we discussed today, we discussed about the surgical chest pain, which is related to Bohr-Havi syndrome, barotrauma. We discussed how the esophagus ruptures after 4 bottle vodka binge drinking. We discussed about the iatrogenic esophageal perforation in the upper esophagus. We discussed about the different foreign bodies. Here I would just recommend all of you beta that you can just go and search the Google for different foreign bodies and try to compare the different images there. If the foreign body is in the esophagus, on a front x-ray it will look like circular. If you take a lateral x-ray, then it will appear a linear shadow. Okay. Just to show you this better, let's see. If there is a coin in the esophagus, then on the front x-ray, you see a circular shadow like this. But if you are taking an x-ray from a lateral view, then this will not appear circular, it will appear as a line. Exactly opposite in case of trachea. In trachea, if you are taking an x-ray from the front, the coin in trachea cannot lie like this. The coin actually tilts because of the vocal cords in the trachea. So on a front X-ray, it looks a linear shadow, and on a lateral X-ray, it looks as a circular shadow. We will remember only one thing so that we do not confuse ourselves. On a front X-ray, in the esophagus, the coin appears circular. Then you just create the opposite stories. Let us look at few more pictures. Now beta, tell me what is this? Whether this coin is in the esophagus or in the trachea. ये क्या है बेटा? फ्रंट व्यू में कॉइन कैसा दिख रहा है? सर्कुलर दिख रहा है, राइट? So this is esophagus, and on a lateral X-ray, you can see it is appearing as a linear shadow. Abhi this coin is in the esophagus again. Okay. Now see this picture. Now here this is a linear shadow on the front X-ray. So this is trachea. Again a linear shadow. So again a trachea story. Right. Chale beta. Now let's take a look about the epigastric pain story. Now in epigastric pain, what can be the different reasons? Let us first try to just understand the different stories. Whenever we say epigastric pain, let us first try to understand right. So what is epigastrium beta? Epigastrium is the topmost part of your abdomen in the center, and the people who are living in this area, their stomach and duodenum, right? Right. So the epigastric pain story would be mostly related to the stomach or duodenum area. We know that in the retroperitoneum here there is pancreas. So whenever there is an acute inflammation of the pancreas, that is pancreas becomes red hot, then the patient can also present with pain in the central upper abdomen, but that central upper abdominal pain usually radiates to the back. If there is a red hot inflamed gallbladder lie in the right hypochondrium, right? So because of this, sometimes the patient may experience pain in the epigastrium, right? Okay. Now regarding these epigastric pains, we'll mainly focus on the stomach and the duodenum first. There might be something inside the stomach or duodenum. Something can be itis. Itis simply means inflammation, right? Gastritis, duodenitis. There may be something like ulcers, right? When the irritation or the insult goes on, then the mucosa can break and result in a ulcer. So a gastric ulcer, a duodenal ulcer, right beta? The story of gastritis and duodeptic ulcers is almost the same, right? So we are just trying to correlate the entire story and try to sort everything in one go. The gastritis and the peptic ulcer story, right? Just excuse me for a minute. Okay, right. So we were just talking about this gastritis and the peptic ulcer story. Now, if we just first focus on gastritis part beta, there can be acute gastritis, there can be chronic gastritis. Just remember what I'm trying to say. Just have a look at this picture here. This is the stomach we know about. Herein, if you carefully take a look, it is just the inflammation what is being shown here. So just inflammation of the stomach mucosa is gastritis. But in this particular picture, if you see here, if this mucosa breaks, breach in the continuity of epithelium or mucous membrane is a ulcer. So one thing which is very clear to our minds, beta, that if there is anybody, anyone who is going to cause irritation, right? If there is some irritation in this area, whether somebody is taking alcohol, smoking, Helicobacter pylori, spirits, spicy food, right? If that is causing simple irritation, it will cause itis, that is gastritis. If the irritation continues, the same story can cause ulcer. है ना बेटा? Now if we try to understand the different types, like there is a acute and chronic gastritis. Acute simply means which is sudden in onset, severe in presentation, and which may carry high mortality also. But the best part would be that if doctor is good, if the doctor is aggressive in the management, then this acute condition passes off suddenly without any major challenges, right? I repeat this in Hindi, beta. Acute का मतलब क्या है? कोई ऐसी चीज जो अचानक से आती है, खतरनाक तरह से प्रेजेंट करती है, पेशेंट को एकदम हिला देती है, घर वालों को हिला देती है। लेकिन अच्छी बात क्या है, जितनी तेजी से आती है उतनी तेजी से ही चली भी जाती है, कभी कभी ले भी जाती है। तो अगर डॉक्टर अच्छा है और एग्रेसिवली इसको मैनेज कर सकता है तो पेशेंट की जिंदगी बच जाती है और बहुत ज्यादा आगे कोई तकलीफ नहीं होती। ठीक। Chronic is something which is present there for a long period of time, which keeps on irritating sometimes in between. And then it depends. If the patient has got time, he can come to the hospital in the OPD and you can investigate these chronic situations. You can make the diagnosis, and then if the patient is willing to go ahead with the treatment, you can plan the treatment for these chronic conditions accordingly, right? Okay. So if we focus on acute gastritis means sudden inflammation of the gastric mucosa. अचानक से inflammation हो रहा है. How this can happen? 4 बोतल वोडका, right? Non-steroidal anti-inflammatory drugs. People who have a habit of taking those analgesics like diclofenac or combiflam type of tablets, right? There are people who start feeling, get up in the morning and they start thinking, "Arey yaar, probably I might get headache today, so let me take that analgesic before that." Right? So there are a lot of people who have a habit of taking these non-steroidal anti-inflammatory drugs. These are going to cause insult to the stomach mucosa. Smoking, Helicobacter pylori produces toxins. These toxins damage the stomach mucosa. So anything of these sort, if the irritation is more, like 4 bottle vodka, you can just imagine what will happen inside the stomach. This 4 bottle vodka is going to cause multiple erosions in the stomach mucosa, and these multiple erosions will start bleeding and blood will get collected inside the stomach. Now blood inside the stomach, just imagine beta, some of you might have seen in the college university days, maybe some of your friends, Friday night, Saturday night, huge drinking, and then maybe after that there's bleeding inside the stomach, and then the person would have vomited blood in vomiting. What is that called as beta? Blood in vomiting. खून की उल्टी जो होती है उसको क्या बोलते हैं? Hematemesis. Emesis, vomiting. Heme, blood. Heme in emesis. Hematemesis, blood in vomiting. Okay, so hematemesis can be there, or this patient may also pass this blood from the anus, right? Now obviously whenever we talk about upper GI bleed, look at me beta, upper GI bleed means the stomach or the duodenum bleeds. When this blood has to pass out through the anus, there is a long journey which this blood has to travel. 6 meters is the intestine, and then there will be cecum, ascending colon, transverse descending colon, sigmoid colon, rectum, and the anal canal. So this is a long journey which takes a long time. maybe 12 hours, 14 hours, 16 hours time. And during this journey, the red hemoglobin will disintegrate into brown black. And what patient passes out is not red, is black. Black tarry stools. Tarry, sticky. Why sticky? Because the entire intestine, the small intestine, the large intestine, lined by mucosa, goblet cell, mucus. So when this blood is passing through the lumen of the intestine, it is getting mixed with mucus all over the place. So what the patient is passing is a black, sticky mucus stool, just like the coal tar. Coal tar is that liquid which is put before the roads are actually laid, right? So that black tarry, this is what we call as melena. And melena simply indicates there is a upper GI bleed. Upper GI means there is a bleed in the stomach or the duodenum, right? Okay, beta. So let us come back. 4 bottle vodka, gastric erosions, bleeding, hematomasis. You are the boss. February 23, 2 o'clock in the night, Saturday night. You receive a patient who is having hematomasis. The first and foremost thing in acute conditions is to save the life. If the patient has vomited blood significantly, we know there would be a huge amount of blood loss in this patient. And the patient might go into a state of shock also. So you have to stabilize these patients. You start pumping in IV fluids. Pump in normal saline in these situations, right? So when you're pumping in normal saline, the patient might be getting stabilized. If the patient does not get stabilized, if there is more than 30% of blood loss, then you can give blood transfusions. You can give tranexamic acid also, right? Sometimes, if the patient is getting stabilized by this, then the bleeding may get controlled, may not stop properly, but may get controlled. If the bleeding has not stopped completely, the patient is still bleeding, then you can do a upper GI endoscopy to see from where the bleeding is taking place. And when you are doing a upper GI endoscopy and you see a bleeding right in front of you on endoscopy, you can do something in that bleeding area. You can push some sclerosing agent or adrenaline or diathermy, that is cautery, heat, or you can put clips on the bleeding vessel, right? And on endoscopy, if you see a bleeding vessel, you can destroy that bleeding vessel by any of these methods and the bleeding can stop. Sometimes the patient may still be bleeding. You do the endoscopy and you don't see any bleeding vessel on endoscopy. What can be the reason? Just imagine, beta, what I'm trying to say. मैं ये कह रहा हूं कि भैया पेशेंट के अंदर ब्लीडिंग तो हो रही है, हमने एंडोस्कोपी की लेकिन हमें कोई ब्लीडिंग दिखाई नहीं दी. I repeat this in English. What I'm trying to explain is that there is bleeding going on inside the patient. The patient pulse is telling us tachycardia. But when we are doing the endoscopy, we are not able to see any bleed. The reason for this may be submucosal bleed, bleeding in the submucosa. On endoscopy, you are seeing only the lumen and the mucosa. If there is a bleeding beneath the mucosa, you will not be able to see that on endoscopy. So in these cases, you can just puncture the femoral artery, put the contrast in the femoral artery. This contrast will travel to all the vessels inside the body, and when you're looking at the screen, if there is any bleed from any vessel in the body, you will see the contrast leaking out from the site of bleed. That means angiography. And whenever on angiography you come to know ki bhaiya there is a bleeding in any vessel, then you can do angioembolization. You can just take a coil type of substance and just seal that bleeding point with a coil, which we call as angioembolization or therapeutic embolization, right? Very rarely there are situations that despite giving IV fluids, blood transfusion, tranexamic acid, we feel that patient is not getting stabilized. Boss, you are pumping in normal saline like anything, blood like anything. Suppose you have pumped in 6 units of blood, patient is not getting stabilized. That means there is a major bleeding inside. If you just keep on pumping IV fluids and blood, The bleeding is not stopping at all. There's a major bleed inside. Now, to save the life of this patient, you have to stop the bleed. And you know, doctors, that in such cases, you have to open that area, do a laparotomy, do a gastrotomy, open the stomach, identify the bleeding vessel, and ligate the bleeding vessel by surgery. But these are rare situations in upper GI bleed where you have to do a gastrotomy and ligate the bleeding vessel, right? Now let us summarize this acute gastritis story once again. Just close your eyes and just try to understand. Acute is something which is sudden in onset. Whenever there is sudden huge amount of insult to the stomach mucosa, maybe because of char bottled vodka, or maybe because of non-steroidal anti-inflammatory drugs, smoking, Helicobacter pylori, any of these things, multiple erosions inside the stomach mucosa, huge amount of bleeding in the stomach, patient presenting with hematomasis, or patient may also have melena, but hematomasis looks to be quite severe. In these cases, the first and foremost thing is save the life. Give IV fluids, if needed blood transfusion and tranexamic acid. If the patient is getting stabilized but the bleeding is going on, maybe a little bleed going on, do a upper GI endoscopy. If you see the bleeding vessel on endoscopy, use something to destroy, to seal those bleeding points. If you do not see any bleed on endoscopy, but the patient's vitals suggest that patient is still bleeding, do a angiography, identify the bleeding site on angiography, use the Fogarty catheter and leave a coil or embolus at the site of bleed so as to stop the bleed. That is angioembolization or therapeutic embolization. Nowadays, these are very commonly used. If suppose, even after pumping in IV fluids, blood, tranexamic acid, you feel that patient is not getting stabilized at all, there is a major bleed going on, you have pumped in 6 blood units, that also is not stabilizing the patient, this is the indication for doing a laparotomy, gastrotomy, and ligation of the bleeding vessel to save the life of this patient, right? Okay, so this is the story of acute gastritis. Let's have a look. So acute gastritis, beta, these are non-steroidal anti-inflammatory drugs, that is analgesics, smoking, H. pylori, and even alcohol. Patient is presenting with hematomasis. Hematomasis is blood and vomiting. We'll just write about this story a little later on. Let us just see how to approach these patients in hematomasis. Beta, we'll be writing this just a little later on. I'm just trying to maintain that continuity in your mind. कि patient is having hematomasis. अभी क्या करना है? What we are supposed to do? First we give IV fluids, beta. If more than 30% of blood loss is there, then we are giving blood transfusion. BT is blood transfusion, right? We can also give tranexamic acid. First dose within 10 minutes or maybe within 3 hours, and the second dose to be repeated within 8 hours of first dose. If suppose we are giving all this and we still feel that bleeding is going on, then first investigation to see from where the bleed is going on is upper GI endoscopy, depending on whether you are able to see the bleeding vessel or not. If you are able to see the bleeding vessel on endoscopy, beta, then on endoscopy you can do something like sclerotherapy, adrenaline, diathermy, or clips and seal that bleeding point. If you are not able to see the bleeding vessel on endoscopy, then second investigation is angiography. Angiography. For this, beta, we know Fogarty catheter is something what we are using in vascular surgery. Now on angiography, suppose I say beta that this is the contrast which is traveling. Suppose this is the contrast which is traveling here. Now you all can understand beta that if there is a leak here, what is going to happen? This is going to leak from this area, right? The contrast will leak from this area. So you will be seeing something like this. And that is how you will be able to identify that yes, this is the site of bleed. Now what you can do is, you have done the angiography already and you know there is a leak in this particular area. Now you pass a Fogarty catheter beta, load a embolus on the Fogarty catheter, maybe a coil type of thing. This is the Fogarty which is being passed. There is a embolus at the tip of the Fogarty, and just leave this embolus here like this. This is a coil which can be placed here. This coil has got hooks. With the help of hooks, we attach this coil to the wall of the vessel so that this coil does not move inside the vessel. Right? This is what we call as angioembolization or therapeutic embolization. Rarely beta we come across situations where despite giving an IV fluids, blood transfusion, trying all these methods, the bleeding is not stopping. If by chance, if patient is not getting stabilized, even after 6 units of blood transfusion, then we have to do surgery to control the bleed. In this, we do a laparotomy, gastrotomy, and ligate the bleeding vessel. If patient is not getting stabilized even after 6 units of blood transfusion, we do a surgery to control the bleed, laparotomy, gastrotomy, and ligate the bleeding vessel. Now if we take a look at the other things beta, लिख लिया बेटा? I hope you have written this beta. Fine. See, here what we are trying to do is, since we talked about hematemesis, so let us take a look at what can be the causes of hematemesis. That is vomiting of blood from the mouth. At the same time only beta, we'll also write what can be the causes of bleeding per rectum. ऊपर से खून के कॉजेज देख लेते हैं और नीचे से भी खून के कॉजेज देख लेते हैं. फ्रॉम द माउथ हेमाटेमेसिस, फ्रॉम द एनल कैनाल ब्लीडिंग पर रेक्टम. ठीक है. मोस्ट कॉमन कॉज ऑफ हेमाटेमेसिस बेटा, हेमाटेमेसिस मोस्ट कॉमन कॉज this is peptic ulcer, and herein it is the duodenal ulcer beta. Peptic ulcer can be duodenal or gastric ulcers. It is the duodenal ulcer which bleeds more commonly, and that can present as hematemesis. Apart from this, there can be gastric erosions, Mallory-Weiss tear. Mallory-Weiss tear we'll be discussing just after this. Esophageal varices. This is seen in portal hypertension. For example, if you get a story of a alcoholic cirrhosis of liver, or maybe non-alcoholic cirrhosis of liver, liver damage basically leading to portal hypertension can lead to esophageal varices. So 4th of June 2022, there was a story of an alcoholic person whose liver was damaged and he was presenting with hematemesis. What can be the likely cause? So all these options were there, and the best answer there was esophageal varices. If they are cooking a story of portal hypertension, esophageal varices will be there and that can lead to hematemesis. अच्छा बेटा, ऊपर से ब्लीडिंग का देख लिया, अभी नीचे से ब्लीडिंग का देख लेते हैं. मोस्ट कॉमन कॉज ऑफ ब्लीडिंग पर रेक्टम. ये पीआर जो है ना बेटा, ये पीआर इज पर रेक्टम, राइट, पर रेक्टम. मोस्ट कॉमन कॉज इज hemorrhoids, or we can say piles. Most common causes hemorrhoids or piles. Most common cause of bleeding per rectum in an infant. छोटा सा बेबी है ना बेटा, 1 साल का कम बच्चा है, तो into susception. However, more than 1 year of age, but in a child, it is juvenile polyp. जुवेनाइल पॉलिप जो होते हैं ना बेटा, ये छोटे छोटे से मस्से जैसे होते हैं. These are small cherry tumors. Many times they are seen in small babies in the rectum, and they can bleed. In case of adults बेटा, hemorrhoids or piles. अच्छा, elderly लोगों में बेटा colorectal cancer. However, there is another common cause of bleeding per rectum in elderly, and that is diverticulosis of colon. All these bleeds now, what you are seeing beta, they are from the left side mainly. Into susception is generally ileocolic, so that is right side. Rest everything what you are seeing, juvenile polyp, hemorrhoids, colorectal cancer, diverticulars, they are more common on the left side. But in case of elderly, we may find bleed from the right colon. जैसे जैसे उम्र बढ़ती है, इमारतें कमजोर होती हैं, as we are growing older, the walls become weaker and weaker. The same thing may happen with the wall of the blood vessels, and especially in the right colon, the cecum and ascending colon, especially the ascending colon, the vessels in the wall of the ascending colon, they become dysplastic, and there may be dilatations in those vessels in the ascending colon which can bleed. That is called as angiodysplasia of colon. क्या बोलते बेटा उसको? Angiodysplasia of colon. अच्छा बेटा, if you give me the permission, can we try to learn these causes? एक बार याद करने की कोशिश कर लें इनको. चलिए एक बार याद करने की कोशिश करेंगे बेटा. The common cause of hematemesis cause क्या हो सकता है? Peptic ulcer, right? The duodenal ulcer, even gastric erosions, Mallory-Weiss tear, and esophageal varices. Bleeding per rectum, hemorrhoids, piles. Infant, into susception. Child, juvenile polyp. Adult, hemorrhoids. Elderly, colorectal cancer. Even diverticulosis of colon can occur, causing bleeding. And right colon bleed in elderly people. Angiodysplasia of colon. एक बार फिर से करेंगे बेटा. हेमाटोमेसिस के कॉजेस में पेप्टिक अल्सर, ड्यूडेनल अल्सर, गैस्ट्रिक इरोजन, मैलोरी-वीस, इसोफेजियल वेराइसिस. Bleeding per rectum, most common overall, hemorrhoids, piles. infant intussusception, child juvenile polyp, adult piles, elderly cancer, right? In elderly people, diverticulosis of colon is also there, and the right colon bleed in elderly is from angiodysplasia of colon, right? एंजियोडिस्प्लेसिया ऑफ कोलॉन। एक बार फिर से करेंगे बेटा इसको, राइट। सो बेटा हेमाटोमैसिस, पेप्टिक अल्सर, ड्यूडनल अल्सर, गैस्ट्रिक इरोजन, मेलोरिवीस, ईसोफेजियल वेराइसिस, ब्लीडिंग पर रेक्टम, हेमरॉइड्स, पाइल्स, infant intussusception, child juvenile polyp, adult hemorrhoids, piles, elderly colorectal cancer, diverticulosis of colon, right colon bleed elderly, angiodysplasia of colon। अच्छा बेटा, hematomasis most common, other causes, bleeding per rectum most common cause, bleeding per rectum infant, child, adult, elderly, another cause in elderly, right colon bleed elderly, very good, wonderful। एक बार फिर से करेंगे बेटा, हेमाटोमैसिस, what are the other causes, bleeding per rectum most common cause, bleeding per rectum infant, child, adult, elderly, another cause of elderly, right colon bleed elderly, very good, perfect। मेलोरिवीस टीयर बेटा, मेलोरिवीस टीयर क्या होता है, मेलोरिवीस टीयर इज अ लॉन्गिट्यूडनल म्यूकोसल टीयर। अगेन बेटा, this is related to 4 bottle vodka, binge drinking। So we were talking about that there are 2 questions on binge drinking. One is related to Boerhaave, another is Melorevis tear. What happens here in what you can see, suppose this is the esophagus beta and here this is the stomach. Now what happens sometimes, if suppose somebody has taken 4 bottle vodka, high pressure irritation of the gastric mucosa, because of which there will be forceful vomiting, and in this forceful vomiting what can happen, the vodka will come up with force. In Boerhaave what used to happen, it used to cause perforation here, but in Melorevis what happens, it is not a perforation, but because of this there is a tear in the mucosa here, there is a tear in the mucosa, just the mucosal tear बेटा। अपने को पता है ना क्या लेयर्स होती हैं, म्यूकोसा, सबम्यूकोसा, मसल, सिरोसा। In Melorevis tear it is not a perforation, it is just a tear in the mucosa, यहाँ से म्यूकोसा छिल गई है, okay? So this condition will start presenting with bleed, and bleed inside the stomach can present with हेमाटोमैसिस। ठीक है बेटा, प्लीज डू नॉट कंफ्यूज दिस मेलोरिवीस विद बोरहावी। बोरहावी क्या होता था बेटा, बोरहावी वाज इन द esophagus here, okay? Just focus, both Boerhaave and Melorevis, they are associated with 4 bottle vodka। In Boerhaave what used to happen, the esophagus perforated, mucosa, submucosa, muscle, all were getting involved, transmural। Melorevis, first of all, it is not the esophagus, it is the stomach। This is, Melorevis is below the gastroesophageal junction, it is just a mucosal tear, सिर्फ mucosa में इंजरी हो रही है बेटा, it is not a transmural story। In Boerhaave what used to happen, the gastric contents used to leak in the mediastinum, So there was a bacterial party in the mediastinum which causes chest pain. In Mallory-Weiss, there is no chest pain. In Mallory-Weiss, there is bleeding. So if in the exam 17th of December, hot question, if the scenario is binge drinking and the presentation is hematemesis, then the answer is Mallory-Weiss. If there is binge drinking and presentation is chest pain, then the answer is Bohr-Harvey syndrome. Right, beta? Chaliye. So in Mallory-Weiss tear, what happens? It is just a longitudinal mucosal tear. This, what you're seeing, beta, this is the gastroesophageal junction, right? Above is the esophagus, and below everything, what you're seeing, this is the stomach. Now, 4 bottle vodka, forceful vomiting, that has just caused a tear in the mucosa. ये जो mucosa दिख रही है बेटा, यहाँ पे सिर्फ ये छिल गई है. It is just a tear. So this will bleed, and then the patient will present with hematemesis. Okay. So Mallory-Weiss tear, beta, this is a longitudinal mucosal tear. Longitudinal mucosal tear in the stomach, या gastric mucosa. It is associated with binge drinking. Associated with binge drinking. 4 bottle vodka. Most commonly seen in elderly people, most commonly presents with hematemesis. This is the site of Mallory-Weiss tear is cardia of stomach. Cardia of stomach. That is just below the gastroesophageal junction. This part of the stomach, beta, this part is the cardia of stomach. This part is the fundus of stomach. This part is the body of stomach. This part is the prepyloric or the antrum of stomach. And this is the pylorus of stomach. So the different parts, beta, this is the cardia, this is the fundus, this is the body, this is the antrum or the prepyloric region, and this is the pyloric region. Mallory-Weiss tear in the cardia of stomach just below the gastroesophageal junction. Right? ध्यान रखना बेटा, दोबारा से I repeat this in Hindi also. Bohr-Harvey syndrome और Mallory-Weiss tear दोनों ही अल्कोहल से रिलेटेड है. 4 बोतल वोडका बिंज ड्रिंकिंग करके आता है क्वेश्चन में. अभी बिंज ड्रिंकिंग से क्या होता है, स्टमक की मसल जोर से कॉन्ट्रैक्ट करती है, स्टमक को इरिटेशन होता है, तो पेशेंट को फोर्सफुल वॉमिटिंग होती है. और वॉमिटिंग में बेटा हो सकता है स्टमक म्यूकोसा छिल जाए, उसको अपन मैलोरी-वीस टीयर बोलते हैं. हो सकता है कि प्रेशर इतना ज़्यादा हो कि ईसोफेगस उतना प्रेशर बर्दाश्त ना कर पाए और उसकी वजह से ईसोफेगस फट जाए, तो वो बोर-हावी सिंड्रोम होता है. अगर ईसोफेगस फटेगा तो जो भी सामान है वो मीडास्टिनम में निकलेगा, मीडास्टिनाइटिस होगी, सेप्टिसीमिया होगा, छाती में दर्द होगा. लेकिन अगर सिर्फ स्टमक की म्यूकोसा छिलेगी तो सिर्फ ब्लीडिंग होगी, ये ब्लड स्टमक में होगा जो उल्टी में बाहर आएगा, तो हिमेटेमेसिस होगी. तो 17 दिसंबर को व्हाट यू हैव टू टेक केयर, बिंज ड्रिंकिंग, चेस्ट पेन, बोर-हावी. बिंज ड्रिंकिंग, हिमेटेमेसिस, मैलोरी-वीस टीयर. बात समझ आई बेटा? वेरी गुड. चलिए, So now here what we'll do is we'll take a break here, and then we'll be back at 11:35 p.m. Right? Break for 20 minutes, rather 11:37 p.m. ठीक है बेटा जी, thank you very much. Same link. Do not go anywhere. Just relax yourself. Have a cup of coffee, or you can just rewind. Just revisit if you want. Thank you. Hello, hello. Yeah. Right, beta. So now let's take a look at the chronic gastritis story. Chronic gastritis, we'll just try to understand beta first. Like chronic is something which is present for a long period of time. Type A and type B. Type A is autoimmune. So what happens in this autoimmune gastritis? Antibodies are formed against the parietal cells. We'll just try to understand it here. Now suppose beta in this particular image, if we try to understand, suppose this is the esophagus, and now here we are talking about the type A gastritis story. So herein, suppose beta, this what you are seeing, this is the esophagus and this is the stomach. Now we know inside the stomach, God has given the parietal cells. Suppose the pinky thing what you are seeing, these are the parietal cells. These are abundant in the fundus and the body of the stomach. And the job of these parietal cells beta is to produce HCl and intrinsic factor, right? HCl is acid and intrinsic factor is something which is required for absorption of vitamin B12, right beta? Now just imagine sometimes what can happen, antibodies can develop, and autoimmune term जहाँ भी आता है ना बेटा, wherever you use autoimmune, immune, antibody. So there might be so many autoimmune diseases which you will be reading in all the 19 subjects. Just imagine one thing beta, in autoimmune means there is something which is related to immune response, right? Antibodies would be forming in that particular patient. These antibodies can either be stimulating antibodies or destructive antibodies. Now here what happens, there are destructive antibodies. Destructive means, suppose I say beta that these antibodies are formed against the parietal cells. Now what these antibodies are going to do, they will not allow the parietal cells to work. And what is the work of parietal cells? That is to produce acid and intrinsic factor. Acha, ab tell me beta, if these antibodies are not allowing this, so what will happen to acid secretion? Acid secretion will decrease, right? So there will be hypochlorhydria. Hypochlorhydria. Whenever acid secretion decreases inside the stomach, there is an auto-regulation in the stomach by the G cells. Now G cells beta, they are located in the antrum of the stomach. G cells are located in the antrum of the stomach. And the job of the G cell is to produce gastrin, right? Look at the screen once again beta. If there is reduced acid secretion inside the stomach, whatever may be the reason, the G cells will be stimulated and their job is to produce gastrin. And gastrin, in turn, what it causes beta, it actually stimulates the parietal cells. It stimulates the parietal cells to produce acid secretion. And because of this stimulation, the parietal cells increase the acid secretion. So this is what is auto-regulation. I repeat, whenever acid secretion goes down inside the stomach, the G cells become active, they produce more gastrin, and then gastrin stimulates the parietal cells to produce acid. Now what happens in this autoimmune gastritis? Look at the screen. Antibodies are formed against the parietal cells. So these antibodies are not allowing the acid to come out. The G cells are stimulated, they are producing more gastrin, hypergastrinemia. This gastrin is trying to stimulate the parietal cells, but the antibodies are not allowing the acid to come out. So parietal cells are getting troubled. Parietal cells की हालत देखिए बेटा, जी सेल से गैस्ट्रिन निकला, गैस्ट्रिन क्या कर रहा है, पेराइटल सेल को डंडे मार रहा है कि निकाल भैया एसिड, निकाल निकाल निकाल, स्टमक में एसिड कम हो रहा है। और पेराइटल सेल कोशिश कर रहे हैं एसिड निकालने की, लेकिन ऊपर एंटीबॉडीज बैठी हैं ऐसे आलती पालती मार के, निकाल HCl, देखते तेरे में दम है तो बेसिकली व्हाट इज हैपनिंग इन दिस सिचुएशन, देयर इज increased gastrin which is trying to stimulate the parietal cell to produce HCl, but the antibodies are not allowing the HCl to come out. So the parietal cells are getting frustrated, and because of this chronic irritation in the parietal cells, a stage comes when these parietal cells undergo changes. Adenomas can develop in the parietal cells. Adenoma term anywhere in GIT is a dangerous term. This can lead to cancer. That means if parietal cells develop adenomas, then the chances of cancer inside the stomach increases. MCQ people have asked that what can be the common site of stomach cancer in this autoimmune gastritis, since parietal cells are most abundant in the fundus of the stomach. So the chances of malignancy in the stomach will be higher in the fundus part of the stomach, right? Also beta, if intrinsic factor is going down, vitamin B12 is not getting absorbed, this is going to cause pernicious anemia. MCQ people have also asked this question कि beta, what is the common site of stomach cancer in pernicious anemia? The answer is fundus of the stomach, right? अब एक बार quickly फिर से इसको समझ लेते हैं, राइट? आई जस्ट एक्सप्लेन दिस इन हिंदी क्विकली। ऑटो इम्यून गैस्ट्राइटिस मतलब एंटीबॉडी का कोई पंगा है। इसमें क्या होता है बेटा, एंटीबॉडी जो है पेराइटल सेल्स के अगेंस्ट बन जाती है और पेराइटल सेल्स को उनका काम नहीं करने देती। पेराइटल सेल के दो काम होते हैं, एक एसिड निकालना और एक इंट्रिंसिक फैक्टर निकालना। अगर एंटीबॉडी आ गई तो एसिड सेक्रीशन कम हो जाएगा, इंट्रिंसिक फैक्टर सेक्रीशन कम हो जाएगा। एसिड कम हुआ मतलब हाइपोक्लोरहाइड्रिया। जब भी स्टमक में एसिड कम होता है, जी सेल स्टिमुलेट होकर गैस्ट्रिन बढ़ा देते हैं, हाइपर गैस्ट्रिनीमिया, और ये गैस्ट्रिन पेराइटल सेल को डंडे मारता है कि भैया निकाल HCl, लेकिन एंटीबॉडी HCl को नहीं निकालने देती, तो पेराइटल सेल्स में फ्रस्ट्रेशन डेवलप हो जाता है और पेराइटल सेल्स में एडिनोमा बन जाते हैं, जिससे कैंसर हो सकता है। दूसरा, इंट्रिंसिक फैक्टर कम हुआ तो विटामिन B12 का एब्जॉर्प्शन नहीं होगा, परनीशियस एनीमिया हो जाएगा। परनीशियस एनीमिया में स्टमक के कैंसर किस इलाके में होता है, तो वो फंडस में होता है, क्योंकि पेराइटल सेल की मात्रा फंडस में सबसे ज्यादा है। आई रिपीट दिस एक्सप्लेनेशन इन इंग्लिश ऑल्सो बेटा। Autoimmune gastritis or type A gastritis, basically antibodies are formed against the parietal cells, and these antibodies do not allow the parietal cells to work. So parietal cells are not able to release acid and intrinsic factor. Whenever acid secretion goes down in the stomach, the G cells are stimulated to produce gastrin, hypergastrinemia. This gastrin stimulates the parietal cell to produce acid, but antibodies do not allow the acid to come out, so parietal cells get frustrated over a long period of time and cancer can develop because of adenomas in the parietal cell. Since intrinsic factor is also not coming out, vitamin B12 is not getting absorbed, pernicious anemia. The commonest site of stomach cancer in pernicious anemia is the fundus of stomach, because fundus is having the maximum abundance of parietal cells, right? Chale beta, let's move. So type A gastritis or autoimmune gastritis, antibodies are formed against the parietal cells. This is also called as autoimmune gastritis, also called as atrophic gastritis. What happens if antibodies form against the parietal cells? Then these antibodies do not allow the parietal cells to work. So there is reduced acid, reduced intrinsic factor. Reduced acid means hypochlorhydria. This will stimulate the gastrin secretion. This will cause hypergastrinemia. Most common cause of hypergastrinemia is this condition, atrophic gastritis. Despite high gastrin, the parietal cells are not able to produce acid. So frustration will develop in parietal cells, adenomas will develop, cancer can occur. Now when intrinsic factor goes down, then absorption of vitamin B12 does not occur. So that causes pernicious anemia. Most common site of stomach cancer in pernicious anemia is the fundus of stomach. Right. So this was the story of autoimmune gastritis. Acha, now let's talk about type B. Now B is bacteria. So type B gastritis is the story of bacteria. And which bacteria in the stomach and duodenum? Helicobacter pylori. I received a question 2 or 3 days back, beta. I do not remember the name exactly at this point of time, but yes, I have saved that in my contacts. And that was an interesting question. Ki doctor, when there is so much of acid inside the stomach, how can any bacteria survive in the stomach? हम सब जानते हैं बेटा कि हमारे स्टमक में इतनी आग है कि कोई जिंदा कैसे रह सकता है, और वो भी एक बैक्टीरिया इतनी आग में कैसे जिंदा रह सकता है? Very valid question. Nobody can survive, no bacteria can survive in such strong acidic environment. But H. pylori can do that because H. pylori produces an enzyme. That is the MCQ enzyme, urease. And you know what this urease does? It actually splits urea into ammonia. And ammonia is alkaline. So in the antrum of the stomach, this H. pylori, because it is creating ammonia, it is creating an alkaline environment around itself. And that is the reason why, despite so much of acid in the stomach, because H. pylori is converting urea into ammonia, ammonia being alkaline, H. pylori creates an alkaline environment around itself. And that is how it is able to survive inside the stomach. Very good, beta. Now, if I say that this bacteria inside the stomach becomes notorious and it starts causing problems, it can cause problem in the stomach as well as in the duodenum. Abhi stomach mein kya hota hai beta? This bacteria produces some toxins like CAG-A, VAC-A, proteases, phospholipases, and these toxins can directly cause damage to the stomach mucosa. That is why this can cause gastritis, gastric ulcer, and even gastric cancer. Cancer, we know beta, one of the main factors for cancer, long-term irritation. So if this bacteria is irritating the stomach mucosa for a long period of time, the chances of stomach cancer will be high. Okay. How this bacteria causes duodenal ulcers? This bacteria is producing enzyme urease, and urease is splitting urea into ammonia. Ammonia is alkaline. Oh my God. Stomach. There is huge acid inside the stomach, and this bacteria starts creating alkali inside the stomach. Oh my God. So parietal cells are looking at this. What the hell is happening inside the stomach? Why alkali is coming in the stomach? And the parietal cells want to counter that. So they start producing more and more acid. Now, whenever there is huge amount of acid coming in the stomach, dhyan se suniyega, look at me on the screen. Whenever there is huge amount of acid coming inside the stomach, if suppose the stomach mucus barrier is intact, then even this high acid will not be able to cause any damage to the stomach mucosa. In such cases, this high acid will be going towards the duodenum, And unfortunately, the first part of duodenum is going to face this huge amount of acid. Unfortunately, God has not given this strong barrier in the first part of duodenum. So whenever high acid comes in the first part of duodenum, it can directly cause damage to the duodenal mucosa, leading to duodenitis and duodenal ulcers. I repeat this story, beta. How this bacteria can cause problems in the stomach and duodenum. There are two things. The stomach problems by the bacteria are related to the toxins produced by the bacteria, Kage, Veke, proteases, phospholipases. Just close your eyes and try to listen and focus. If there is H. pylori in the stomach and it is producing toxins in the stomach, these toxins can cause direct damage to the stomach mucosa, which can lead to gastritis. Gradually, a gastric ulcer can develop, and over a period of years, gastric cancer can develop because of chronic irritation. However, duodenal problems with this bacteria are related to the enzyme produced by the bacteria urease, which splits urea into ammonia. Ammonia is alkaline. If more alkali is getting produced inside the stomach, the parietal cells are watching all this. Now parietal cells want to counter this alkali, so they start producing more and more acid when there is huge amount of acid inside the stomach. But if suppose the mucus barrier in the stomach is intact, then even this high acid will not come in contact with the stomach mucosa. So it is not causing damage to the stomach mucosa, but this high acid will travel down towards the duodenum. First part of duodenum, unfortunately, God has not given a good barrier, mucus barrier to the first part of duodenum. Whenever high acid goes towards the first part of duodenum, this high acid damages the mucosa of the first part of duodenum, and that is how duodenal ulcers can occur because of this bacteria. Whatever is the problem, whether the problem is in the stomach or the problem in the duodenum, that means whether it is gastritis, gastric ulcer or duodenal ulcer, patients will come to you with epigastric pain in February 23. What are you wearing in February 23? Very good. So just imagine a patient of epigastric pain in your OPD. Patient complains of this pain. You know that God has given stomach and duodenum in the epigastrium. So you start thinking that the story would be related to acid, and acid is something which is related to the lifestyle of the person. So first and foremost thing in the OPD, when you take the history, you try to elicit ki bhai, what is the lifestyle, whether he is appearing for FMG exam, whether he is under stress, whether he is having any anxiety, why this high acid is there inside the stomach. We cannot ask this person not to give the FMG exam, but we can just try to counsel the person that do not worry, there are a lot of students who do pass this exam, so you will also be amongst one of them. Don't take too much of tension. Do not over exhaust yourself. Do not overthink about it. Just try to follow the process what you are in. Just try to stick to your consistency model, and small efforts on daily basis, they will definitely make you succeed. So keep on taking those baby steps on a daily basis, especially in the online platform. If you remain focused and dedicated, if you remain pumped up all the time, if you remain motivated and stick to a standard disciplined schedule, complete all the lessons for learning on a daily basis, appear in all Tuesday tests, so that every week you are able to revise the entire story. This will definitely help you in the month of November when you will be doing the revision. If you have put a strong hard work at this point of time, if you have learned your lessons nicely at this point of time, if you have understood the concepts nicely at this point of time, your life in the month of November is going to be very easy. You will be taking less time in revision in November if you have done the learnings nicely in the month of August, September and October. Right. So by doing this, you can just try to relieve some anxiety. The acid secretion may reduce in this person, and if the acid secretion reduces, then the symptoms also reduces. However, in the lifestyle, it is not only about the FMG exam, but he may be a businessman or something continuously under stress related to his business. So you can counsel him accordingly. If he's a smoker, alcoholic, takes a lot of tea, coffee, spicy food and all that stuff, you ask him to avoid all that stuff. That will try to reduce the irritation in the stomach and may help in reducing the symptoms. But we know that this treatment is really expensive and many a times patients are not able to afford this treatment. So what we do to counter this acid, we give that wonder drug. What is the name of that wonder drug? Very good. So you give proton pump inhibitors and the story settles. The symptoms reduce and the patient becomes fine. But beta ji, if the cause of these symptoms is bacteria, then just by giving proton pump inhibitors, this bacteria will not be killed, this bacteria will not be eradicated. There may be reduction in the patient's symptoms, but the patient will come to you again and again, doctor, I think I am not getting complete relief. If this is the situation, you follow the same guidelines what we discussed earlier. Patient of epigastric pain, not getting any relief even after lifestyle modification and PPIs. First investigation to be done in these situations is very good. Upper GI endoscopy. When you are doing a upper GI endoscopy, if you find something in the lower esophagus, you are doing something. If you are finding something inside the stomach, then you are doing something. If you are finding something in the duodenum, then you are doing something. Here, if we are talking about the stomach story, if there is an ulcer inside the stomach, then you take a biopsy from two sides, ulcer to rule out cancer, antrum to rule out H. pylori. If you find something inside the duodenum, you take a biopsy from the antrum for H. pylori. When you take a biopsy and you give this biopsy specimen to the pathologist can take the help of special stains like Athens Starry stains, Giemsa stain, and he can identify this bacteria in that biopsy specimen. We can do a rapid urease test, CLO test, Campylobacter-like organism test. This is just a card test which can confirm the presence of H. pylori on the biopsy specimen. Another test which we can do for H. pylori is a urea breath test. There we give a capsule of urea which is labeled with radioisotope carbon, and this capsule is swallowed by the patient. If there is bacteria inside the stomach, then this urea will be split into ammonia. Ammonia will be absorbed into the patient's circulation, and through the circulation the ammonia will be coming towards the lungs, and then from the lungs it will be excreted in the patient's breath. You put a breath analyzer and just look for ammonia in the breath. If after giving a urea capsule there is ammonia in the patient's breath, then it means the bacteria is present inside the stomach. So that is how we can confirm the presence of this notorious bacteria. If this bacteria is present, we have to eradicate this bacteria. So we have to give antibacterial therapy, which is a combination usually of 2 antibiotics and 1 proton pump inhibitor. We give this eradication therapy for 14 days and this bacteria can be completely eradicated by this therapy, and then the patient will become fine. Right? Chale beta. So I hope you got the concept of this chronic gastritis, the type B gastritis nicely. Let's take a look what all is written here. Type B gastritis, beta, this is related to bacteria H. pylori. There are two things what we need to know. One, the toxins, another the enzyme. So toxins, the CAG, VAC proteases, phospholipases, they cause damage. The gastric acid mucus barrier. They damage the gastric acid mucus barrier, because of which the stomach mucosa comes in contact with these toxins and gets damaged, leading to the gastritis, gastric ulcer, and gastric cancer. Right? So there is damage to the gastric acid mucus barrier. Okay, G. Enzymes like urease, they split urea into ammonia, and ammonia is alkaline. This stimulates the parietal cells to produce more acid. And when more acid comes into the duodenum does not have that barrier, and the duodenal mucosa disrupts, leading to duodenal ulcer. February 23, clinical approach in epigastric pain, बेटा सबसे पहले क्या करेंगे? लाइफस्टाइल मॉडिफिकेशन. Why? Because we want to reduce the acid so that his symptoms can improve. मानेगा क्या? नहीं मानेगा. तो सिम्टम्स गायब होंगे क्या? नहीं होंगे. फिर हम क्या करेंगे? फिर हम देंगे PPIs, प्रोटॉन पंप इनहिबिटर्स, राइट? इससे symptoms will reduce. But if the story is related to bacteria, the symptoms will not disappear. Patient may keep on coming to you. So if this fails, then what we do? Then we do upper GI endoscopy. And when we are doing upper GI endoscopy, if there is a problem in the stomach or duodenum, we can take a biopsy. If you are taking a biopsy from the pre-pyloric region, then you can take the help of various stains like Giemsa and Athens starry silver stains. You can do a rapid urease test, which is called as CLO test. CLO means Campylobacter-like organism. Campylobacter-like organism test is done for Helicobacter pylori. This is just a card test, just like a urine pregnancy test. You drop the urine in the well. If the lines become prominent, then it is positive. Same way the CLO test or rapid urease test can be done. Another test what we can do is a urea breath test, where we use a radio-labeled carbon. This radio-labeled carbon can be a 13 carbon isotope or a 14 carbon isotope. 13 carbon is preferred. And if H. pylori comes out to be positive, if it is positive, then we have to give eradication therapy. And in pharma classes, beta, we will be taught the different types of eradication therapy. Generally, we give this for 14 days, which is a combination of 2 antibiotics and 1 PPI. 2 antibiotics plus 1 PPI. That is how we treat these chronic gastritis. Now, there are some terms which are special different types of gastritis. There is one thing called as Menetrier's disease. In Menetrier's disease, beta, what happens? There is actually gross hypertrophy of the gastric mucosal folds. Now, suppose this is the stomach here, and suppose this is the normal mucosa. Look at the screen beta for a moment. Suppose this is the normal mucosa. Now sometimes what happens, this mucosa is actually thrown into numerous folds, something like this, and this condition increases the risk of cancer inside the stomach. This is what we call as Menetrier's disease. It is a type of gastritis, gross hypertrophy of gastric mucosal folds, which is pre-malignant. That means it can lead to cancer. Erosive gastritis, multiple erosions in the stomach mucosa. This is commonly associated with non-steroidal anti-inflammatory drugs. We can find gastritis in AIDS patient, and there it is most often due to fungus, cryptosporidiosis. We can find eosinophilic gastritis. This is eosinophils beta, allergen mediated, due to some allergy. अगर बॉडी में कभी भी कोई एलर्जी होती है तो eosinophils बढ़ जाते हैं. Allergen mediated is called as eosinophilic gastritis. And reflux gastritis. Now reflux gastritis is something what we need to understand. Acha beta, we know that earlier we discussed about gastroesophageal reflux disease, right? But here we are talking about reflux gastritis. Acha, let me just remind you beta that why GERD occurred. That was because of the lower esophageal sphincter weakness, right? If this was weak beta, then what used to happen? If this was weak, then what used to happen? Then the stomach contents used to go up into the esophagus, and that used to cause damage to the lower esophagus. This was called as GERD or reflux esophagitis. Reflux esophagitis, because damage was to the esophagus. But यहाँ पे we want to talk about reflux gastritis. अच्छा. Now, here normally what we know beta, this is the duodenum, है ना? And beneath this duodenum is the jejunum. Okay. God has given one sphincter here. That is the pyloric sphincter. There is a sphincter which is present here na beta. That is the pyloric sphincter. And it is because of this pyloric sphincter beta, what happens? If the pyloric sphincter is intact, it will not allow the duodenal contents to go into the stomach. Right? I repeat, here is the pyloric sphincter. If the sphincter is intact, then the duodenal contents will not reflux into the stomach. But if you damage this sphincter, if this sphincter is damaged, then the duodenal contents will go back into the stomach. Acha beta, duodenal contents are alkaline and stomach contents are acid. So if we damage this pyloric sphincter, then what will happen? If we damage this pyloric sphincter, then the duodenal contents will go back into the stomach and they are going to cause damage to the stomach mucosa. This is what is reflux gastritis. Now, how this pyloric sphincter is damaged actually, in general, if we try to take a look here, suppose this is the normal story, right? Whenever we are doing any gastric surgery, suppose this what I am drawing is a pancreas here beta. We know that pancreas is lying in the C loop of duodenum here, right? And we also know that pancreas is inseparably fused with the duodenum. Pancreas को duodenum से कोई जुदा नहीं कर सकता, है ना? Suppose I say कि बेटा जी there was a problem inside the stomach. यहाँ पे कोई problem थी, कोई ट्यूमर था, and we are chopping the stomach. So suppose I chop the stomach like this, right? Now after chopping the stomach like this, what I will be left with? I'll be left with this esophagus, this part of the stomach, and then there will be duodenum like this, and then there will be jejunum. Here I know lie the pancreas, right? So abhi, when I remove this part of the stomach, what I am supposed to do, beta? I cannot leave it open like this. I have to connect the stomach with someone. If I try to connect it with the duodenum, there's a problem. Since the duodenum is fixed to the pancreas, look at the screen. Since the duodenum is fused with the pancreas, I will not be able to mobilize the duodenum and bring it close to the stomach. अगर ये ड्यूडनम पैनक्रियास के साथ चिपका हुआ है तो मैं इस ड्यूडनम को इस स्टमक के साथ नहीं जोड़ पाऊंगा. ऐसे केसेस में मुझे उसी की याद आएगी. वो जो शरीफ आदमी होता है ना जीआईटी में, there is one innocent guy in GIT whom we can take the help of, and that is jejunum. So I will transect the jejunum and I will take the distal jejunum and attach it with the stomach. Okay, that I will call as gastrojejunostomy. So beta, now what I'm going to do is, if I'm doing this surgery, this is the esophagus, and suppose this is the stomach. I have removed this part of the stomach, beta. This part of the stomach I have removed. Okay. Now I am left with the duodenum and the jejunum. Suppose this is the duodenum and here it is the jejunum. What I have done is I have transected the jejunum at this point. यहाँ पे मैंने jejunum को काट दिया. अभी this is the jejunum here. So I just take this jejunum. This was the jejunum na beta, right? So what I'll do now is I'll take this jejunum towards the stomach and I'll connect this stomach with the jejunum, right? That means what I'm doing is this. I've connected the stomach with the jejunum. Now if you take a look, beta, is there any pyloric sphincter here? No sphincter. If there is no sphincter in this area, then obviously the gastric acid will be coming in the jejunum. But at the same time, the alkali of the jejunum will be going into the stomach, and this alkali will be causing damage to the stomach. This is reflux of alkali from the jejunum into the stomach. And the damage by the alkali in the stomach is gastritis. This is reflux gastritis. Okay, beta. Reflux esophagitis was when the lower esophageal sphincter got damaged, there was esophagitis. When the pyloric sphincter was damaged, then there will be reflux gastritis. Right? Okay. Now, because of alkali damaging the stomach mucosa, just like what we saw in Barrett's, beta, what happened? The squamous mucosa of the lower esophagus metaplasia into intestinal columnar. Here also, this is also columnar lining, this is also columnar lining, but this is gastric columnar and this is intestinal columnar. So when huge amount of alkali is refluxing into the stomach, then the stomach mucosa would also like to change as the intestinal mucosa or the jejunal mucosa, where there are more number of goblet cells. So this gastric pinky gastric columnar will change into the intestinal columnar, and this is called as intestinal metaplasia in the stomach. So in reflux gastritis, alkaline gastritis. There is intestinal metaplasia which can occur inside the stomach. And what used to happen in Barrett's beta? Long-term irritation, cancer. Which cancer? Adenocarcinoma. Why adeno? Columnar. Here also what will happen? Intestinal metaplasia can lead to adenocarcinoma in the stomach. Okay. This is also columnar. This is also columnar. Cancer here is also adeno. Here is also adenoma. Even after metaplasia, this is columnar. The only difference is this is intestinal columnar. So cancer occurring here will be a adenocarcinoma only. Right, beta? I repeat this story once again. What we have done here is we have done a gastric surgery where we have removed the distal part of the stomach and we have just connected the stomach with the jejunum. There is no sphincter here. So acid will be going down, alkali will be going up. Alkali refluxing into the stomach will cause damage to the stomach mucosa, and that is what we call as reflux gastritis. This reflux gastritis, also called as alkaline gastritis, can lead to intestinal metaplasia in the stomach, which can even lead to adenocarcinoma in the stomach. Oh, that means a patient wherein you have done a gastric surgery where you have removed the stomach partially. In these cases, the chances of cancer developing in the residual stomach are high. उन मरीजों में जिनमें हमने स्टमक का डिस्टल पार्ट निकाल दिया, उन मरीजों में जो बचा हुआ स्टमक है उसमें कैंसर होने का खतरा काफी बढ़ जाता है. आई रिपीट दिस इन हिंदी बेटा वंस. जब भी हम स्टमक की कोई सर्जरी करते हैं जिसमें स्टमक का डिस्टल हिस्सा निकाल दिया जाता है, अब जो बचा हुआ स्टमक है उसको हमें किसी न किसी से तो जोड़ना होगा, चाहे ड्यूडनम से जोड़ें या जेजुनम से जोड़ें. ड्यूडनम से इसलिए जोड़ना पसंद नहीं करते क्योंकि ड्यूडनम भाई साहब जो हैं वो पैनक्रियास के साथ चिपके हुए रहते हैं, तो ड्यूडनम भाई साहब को अलग करना, मोबिलाइज करना थोड़ा दिक्कत देता है. इसलिए जेजुनम भाई साहब जो है वो सबकी मदद करते हैं, फ्री रहते हैं, तो हम चुपचाप जेजुनम भाई साहब को लाके स्टमक से कनेक्ट कर देते हैं. और जब भी हम स्टमक और जेजुनम के बीच में कनेक्शन बिठाएंगे तो हमारे पास कोई स्फिंक्टर थोड़ी है जो हम वहां पे फिट कर देंगे. जब हमने कोई स्फिंक्टर फिट ही नहीं किया है तो क्या हो सकता है? तो स्टमक की कहानी नीचे जेजुनम में भी जाती है और जेजुनम की कहानी ऊपर स्टमक में भी आती है. अब स्टमक में तो एसिड होता है और जेजुनम में तो एल्कली होता है. जब ये एल्कली जेजुनम से स्टमक में आएगा तो स्टमक की म्यूकोसा को छेड़ेगा. उसको हम रिफ्लक्स गैस्ट्राइटिस बोल देते हैं या एल्कलाइन गैस्ट्राइटिस बोल देते हैं. अगर ये एल्कली लगातार स्टमक की म्यूकोसा को छेड़ता ही रहेगा, छेड़ता ही रहेगा, छेड़ता ही रहेगा, तो कब तक बर्दाश्त करेगी स्टमक की म्यूकोसा? एक दिन आएगा जब ये स्टमक की म्यूकोसा जेजुनम की म्यूकोसा जैसा बनना चाहेगी और फिर स्टमक के अंदर इंटेस्टाइनल मेटाप्लेजिया हो जाएगा. और जब भी ये मेटाप्लेजिया की कहानी आने लगती है तो कैंसर होने का खतरा बढ़ जाता है. इसलिए बचे हुए स्टमक में कैंसर होने का खतरा ज्यादा होता है. और कैंसर कौन सा होगा? अगर कॉलमनर की बात कर रहे हैं तो कैंसर वही वाला तो होगा, एडिनोकार्सिनोमा. आई होप कॉन्सेप्ट इज एब्सोल्युटली क्लियर इन आवर माइंड्स, राइट? ओके जी. So reflux gastritis, important concept was there. This is also called as alkaline gastritis. This is commonly noticed after gastric surgery. That is, whenever there will be damage to pyloric sphincter. Damage to pyloric sphincter. There will be reflux of alkali from jejunum into the stomach, which will cause this alkaline gastritis or reflux gastritis. This can cause intestinal metaplasia, which can transform into adenocarcinoma, So this is all about the different types of gastritis, beta. We talked about acute gastritis. Remember, in acute, it is an acute insult. That means a very short insult. Like one day, suppose patient takes huge amount of alcohol, 4 bottle vodka, that can cause acute gastritis, patient presenting with hematomasis. And we know how to approach hematomasis patient. First, we try to stabilize the patient, IV fluids, blood transfusion, tranexamic acid, if needed, upper GI endoscopy, if needed, angiography. If huge amount of bleeding is there and to save the life of the patient, we might have to do surgery and ligate the bleeding vessel. We talked about chronic gastritis type A and type B. A was autoimmune, where there were antibodies which were not allowing the parietal cells to work. Type B gastritis was bacteria, H. pylori. We saw how gastritis and duodenal ulcers can occur and how to approach those patients, how to diagnose H. pylori and how to eradicate that H. pylori. Then we talked about some special types of gastritis like menetrius, erosive, AIDS, eosinophilic and reflux gastritis, and we tried to understand the concept of reflux gastritis. One thing which is very clear in our minds now is if lower esophageal sphincter will be gone, there will be reflux esophagitis. If pyloric sphincter will be gone, then there will be reflux gastritis. And if we just apply the concept in a sphincter of OD, which is located in the second part of duodenum, at the opening of common bile duct and pancreatic duct. If you damage the sphincter of ODI, then there will be reflux of duodenal contents into bile duct and pancreatic duct, which can lead to reflux cholangitis and reflux pancreatitis. ये क्या हुआ? Sphincter of OD. Yes, just trying to apply this concept at other areas wherever there are sphincters. If you remember the ureteric opening in the bladder, we talked about that if somebody damages the ureteric opening in the bladder, then there will be reflux of bladder urine into the ureter. Can you tell me what was the name of the disease? Vesicoureteric reflux. Very good. Acha, what was the investigation of choice for vesicoureteric reflux? Micturating cystourethrogram, MCU, or avoiding cystogram. Right, beta? Chaliye, wonderful. So after the story of gastritis, if we take a look at the story of peptic ulcers, it is almost the same, beta. पहले हमने अभी तक जो बात की, that was just inflammation of the stomach mucosa. Now we are just trying to say कि भैया, if the insult persists for a little longer time, then it can lead to ulcer. Now, if we take a look where these peptic ulcers form, so wherever God has given peptic mucosa, like gastric mucosa, there the chances of these peptic ulcers are high. Now, peptic mucosa can be seen in the first part of duodenum most often, inside the stomach obviously, sometimes lower end of esophagus also. And in pediatric surgery, there was a topic called as Meckel's diverticulum. And in Meckel's diverticula, heterotopic epithelium was present. Most commonly, stomach epithelium was present in the Meckel's diverticula. Oh, so stomach lining if present in the Meckel's diverticula, that can also lead to peptic ulcer. And if suppose we are connecting the stomach with the jejunum, which we did just now, like what we did here, obviously the peptic ulcers can be seen at the opening of stomach and jejunum. Opening is called as stomy. So stoma. Basically, we can see the peptic ulcers at the opening between the stomach and the jejunum. That is called a stomal ulcer, right? So if we take a look at the sites where these peptic ulcers can form, look at the screen, beta G. This is the esophagus. This is the stomach, right? Here, this is the duodenum. And if suppose the patient has got Meckel's diverticula, suppose this is the jejunum beta, and here the intestine would be something like this. If there is a diverticula here, Meckel's diverticula, most commonly beta कहाँ पे बनते हैं पेप्टिक अल्सर, जहाँ भी पेप्टिक म्यूकोसा गैस्ट्रिक म्यूकोसा होती है, like first part of duodenum is the commonest site. This is the commonest site of peptic ulcer. Second commonest site is the stomach, and that too on the lesser curvature of the stomach most often. They can be seen in the lower end of esophagus. They can be seen in Meckel's diverticula. They can even be seen at the stoma of gastrojejunostomy. If you're connecting the stomach with the jejunum, then at the stoma. So these are the common sites of peptic ulcers. Acha ji. Most common site beta, this is the first part of duodenum, D1. D1 matlab first part of duodenum. Second most common site कौन सी है बेटा? Stomach है ना, gastric. And here they are common on the lesser curvature of the stomach. Lesser curvature of the stomach. However, peptic ulcers can also be seen in the lower esophagus, in Meckel's diverticula, in the stoma of gastrojejunostomy. So lower esophagus, Meckel's diverticula, and the stoma of gastrojejunostomy. Most common cause of peptic ulcer beta, वो bacteria है, Helicobacter pylori. And an interesting fact about H. pylori is, now beta, this bacteria has been eradicated from the western countries. जैसे US वगैरह से इस bacteria को भगा दिया गया है. So this bacteria is still a common culprit in the developing countries like India. But western countries it has been eradicated. Okay. Apart from this, और कौन पेप्टिक अल्सर कर सकता है बेटा? सारे एस देख लो. Non-steroidal anti-inflammatory drugs, smoking, alcohol, that is spirits, spices, stress, steroids, syndrome. There is one syndrome called as Zollinger-Ellison syndrome. This is actually a gastrinoma. Now, gastrinoma. Oma means what? Tumor. Oma का मतलब क्या होता है बेटा? Tumor. So this gastrinoma means a gastrin producing tumor. If there is a gastrin producing tumor, तो क्या होगा? Huge amount of gastrin will be produced, and you all know beta, if gastrin levels are high, they are going to stimulate the parietal cells, and parietal cells will produce huge amount of HCl, and this high HCl can cause ulcers, most often in the duodenum, right? The peptic ulcers which are seen in head injury patient, they are called as Cushing ulcers. Peptic ulcers seen in burn patients, they are Curling's ulcer. Peptic ulcer in head injury patient are Cushing's. Peptic ulcer in burn patients are Curling. अच्छा बेटा, skin ulcer in burn patient, they are called as Marjolin's ulcer. And Marjolin's ulcer can transform into squamous cell carcinoma. Venous ulcers, also Marjolin's ulcer, can transform into squamous cell carcinoma, right? So now if we try to discuss what are the differences between duodenal and gastric ulcer. Very simple. We are just trying to focus on these two areas, whether there is a ulcer in the first part of duodenum or there is a ulcer in the lesser curvature of stomach. तो बेटा ये हमारा duodenal ulcer है, ये gastric ulcer है. What is more common? Duodenal ulcer is much more common. Duodenal ulcers are commonly seen in young people, rich people. Size of the ulcer beta, duodenal ulcers are smaller, gastric ulcers are larger. For a simple reason, stomach has got more space, so ulcer can easily expand in the stomach. Duodenal ulcers are smaller, gastric ulcers are larger. The basic pathogenesis for a duodenal ulcer, whenever high amount of acid comes from the stomach, this acid will damage the duodenal mucosa. Reason for stomach ulcers, whenever the gastric mucus barrier will be disrupted, then whatever acid is present in the stomach, that will come in contact with the stomach mucosa and damage the stomach mucosa. That means in stomach ulcers, the acid secretion is not the focus. It is the barrier disruption which is the focus. जब ये म्यूकस बैरियर टूटेगा स्टमक में, तब जो भी एसिड स्टमक के अंदर है वो स्टमक की म्यूकोसा को छेड़ेगा और उससे अल्सर बन सकते हैं. इसका मतलब स्टमक अल्सर्स में एसिड सेक्रेशन से कोई लेना देना नहीं है, चाहे ज्यादा हो, चाहे नॉर्मल हो, चाहे कम हो. लेकिन अगर स्टमक का म्यूकस बैरियर टूट गया है, तब ये एसिड उस स्टमक की म्यूकोसा के कांटेक्ट में आके उसे बर्बाद करेगा. राइट? ओके जी. So let's just try to take a look at some important features, important differences between the two. The duodenal ulcer and the gastric ulcer. Which is more common? It is the duodenal ulcer. Duodenal ulcer is common in younger population, rich people. Usually duodenal ulcers will be small, but gastric ulcers will be large. The basic pathogenesis reason for duodenal ulcer, it is the high HCl secretion. But for stomach ulcers, it is the disruption of gastric mucus barrier. Gastric acid mucus barrier. Disruption of gastric acid mucus barrier is the culprit for stomach ulcers. Regarding acid secretion, it will be high in duodenal ulcer. It can be normal or it can even be low in gastric ulcer. Culprit for gastric ulcer is not the acid, it is the disruption of the barrier. Now, whether it is a gastric ulcer or a duodenal ulcer, we know the patient will present with epigastric pain. Now, how this epigastric pain is related to meals and how on the basis of this we can get an idea ki whether it's a duodenal ulcer or gastric ulcer. For this beta, let us try to understand the story once again, or let us just try to understand what is the relation of this duodenal ulcer and gastric ulcer to meals. खाने से दर्द का क्या रिश्ता है? Just imagine a patient of duodenal ulcer, young patient, rich person. Suppose let us imagine one of the rich people of India, say Mr. Ambani and Mr. Mukesh Ambani's son, Mr. Akash Ambani. We all can understand that he's a great businessman, so he might be under stress all the time and he might be having high acid secretion inside his stomach. So in order to reduce the acid secretion, what all we can do, or what will be his presentation? Just imagine yourself February 23. Close your eyes, beta. Just try to imagine yourself February 23. You are wearing that white coat and the stethoscope, and Mr. Akash Ambani is standing in front of you in your OPD. And he is telling you about his complaints, epigastric pain. Now, if he is having a duodenal ulcer, when you take the history, he will be telling you that, doctor, what happens to me is I usually get free by my work at around 10 o'clock in the night. Then I take the dinner. at 11 o'clock, and then I sleep. At that point of time, everything is normal. Just try to correlate what is happening inside the stomach and the duodenum. At 11 o'clock, suppose he has taken the dinner, and that meal is inside the stomach. Suppose he has taken that idli sambar, or maybe dosa, right? So that idli dosa is inside the stomach at 11 o'clock in the night. You know, beta, that this idli dosa will be there in the stomach for 2 to 3 to 4 hours. And you know what the stomach enzymes are going to do there. These enzymes are just going to break that idli dosa nicely. So for 2 to 3 to 4 hours, whatever acid is secreted, that is being utilized by the idli dosa for breakdown of idli dosa. Once all the breakdown has occurred and idli dosa are no more idli dosa now, and they have become chyme, this chyme will be going towards the duodenum. That means at around 2 o'clock in the night, all this idli dosa have become chyme, and this has moved down towards the duodenum. So 2 o'clock in the night, the stomach is empty. Whatever acid is there inside the stomach, that acid is searching for idli dosa so that acid can break the idli dosa. But if there is no idli dosa in the stomach at 2 o'clock in the night, then this acid will keep on searching here and there. It does not find anyone, so this acid will come towards the duodenum. And if there is an ulcer in the first part of duodenum, as soon as this acid is coming towards the first part of duodenum, or maybe the chyme of idli dosa which is coming in the first part of duodenum, as soon as that hits the ulcer, then Mr. Akash Ambani gets severe epigastric pain. 2 o'clock in the night, Akash Ambani wakes up with severe epigastric pain. This is the presentation. And then nobody knows what happens to Akash Ambani. He goes to the kitchen, he picks up a biscuit box, and he takes 5-6 biscuits into the stomach. As soon as these biscuits go into the stomach, whatever acid was there inside the stomach, now this acid will become busy in breaking down those biscuits. No acid will be going towards the first part of duodenum, and his epigastric pain will be relieved. That means, beta ji, duodenal ulcer pain occurs 2 to 3 to 4 hours after meals. And this pain is relieved by taking food. Because of this reason, Akash Ambani keeps on eating after every 2 to 3 to 4 hours, and he gains weight. Right? Open your eyes. Right, beta. So I hope we try to correlate the pathogenesis of duodenal ulcer in the patient's presentation. Right? Okay. Let's talk about gastric ulcer. Gastric ulcer usually seen in poor people, elderly people, big ulcer inside the stomach. Suppose there is a big ulcer in the stomach. Whenever the patient takes the food hits the ulcer. As soon as the food hits the ulcer, the patient winces in epigastric pain. As soon as he eats something, he develops that epigastric pain. So, pain immediately after taking meals. This is seen in gastric ulcer. Because of this reason, gastric ulcer patients are afraid of eating. They develop food fear. They do not want to eat. Because of this, they lose weight. Right? Now, let us close the eyes once again, beta, and those who are able to understand Hindi, just try to understand this concept in Hindi also. हम इमेजिन कर रहे हैं ड्यूडनल अल्सर के बारे में. ड्यूडनल अल्सर जो कि यंग लोगों में, अमीर लोगों में ज़्यादा कॉमन होते हैं उनकी लाइफस्टाइल की वजह से, क्योंकि अगर अमीर ज़्यादा है तो पैसे की टेंशन ज़्यादा होगी. अगर हर वक्त टेंशन ही लेंगे तो एसिड का सेक्रीशन ज़्यादा होगा. ज़्यादा एसिड बनेगा तो ड्यूडनम में अल्सर भी पड़ जाएंगे. अब मान लेते हैं कि अगर ड्यूडनम में अल्सर है, और हिंदुस्तान में अगर अमीरों की बात करें तो हमारे अंबानी साहब, उनके बेटे साहब श्री आकाश अंबानी जी, अगर मान लेते हैं कि उनको ड्यूडनम में अल्सर है, और फरवरी 2023 में आप जब अपने क्लिनिक में प्रैक्टिस कर रहे हैं, तो हो सकता है आकाश अंबानी साहब एपिगैस्ट्रिक पेन के साथ आपके क्लिनिक में आए। जब वो आपको अपनी कहानी बयां करेंगे तो वो बताएंगे कि मैं रात को 10 बजे ऑफिस का काम निपटा के घर आता हूँ, 11 बजे खाना खाता हूँ, सो जाता हूँ। अब हम इसको कोरिलेट करने की कोशिश करते हैं कि मान लीजिए आकाश अंबानी साहब हैं, उन्होंने रात को 11 बजे इडली डोसा खाया है। ये इडली डोसा 2-3-4 घंटे तक आकाश अंबानी साहब के पेट स्टमक में रहेगा, और जब तक ये इडली डोसा स्टमक में रहेगा तो स्टमक के जो एंजाइम्स वगैरह हैं वो इस इडली डोसा को तोड़ते रहेंगे, एसिड इस इडली डोसा को तोड़ते रहेगा। जितना भी एसिड आकाश अंबानी साहब के स्टमक में है वो सारा का सारा एसिड इस इडली डोसा को तोड़ने में यूज होता रहेगा। यानी कि अगर ड्यूडनम में अल्सर है भी तो भी ये एसिड उस अल्सर की तरफ नहीं जा रहा, ये इडली डोसा उस अल्सर की तरफ नहीं जा रहा, और आकाश अंबानी साहब 11 बजे सो रहे हैं। 12 बज गया, 1 बज गया, 2 बज गया, जैसे ही रात के 2 बजे या 3 बजे जब ये इडली डोसा पूरी तरह से टूट चुका, कायम बन चुका, और जब ये इडली डोसा स्टमक से उतर के ड्यूडनम में आ रहा है, जैसे ही ये ड्यूडनम में आता है वैसे ही ये उस अल्सर से टकराता है, जिसकी वजह से आकाश अंबानी साहब को बहुत जोरों का दर्द होता है एपिगैस्ट्रियम में। इस तरह की कहानी आपको बताई जा रही है। इसके बाद आकाश अंबानी साहब ये भी बताते हैं कि दर्द बहुत ज़्यादा होता है, कुछ समझ नहीं आता, मैं किचन में जाता हूँ, बिस्किट का डिब्बा उठाता हूँ और 5-6 बिस्किट खा लेता हूँ। हम ये समझ रहे हैं कि जब तक इडली डोसा स्टमक में था, एसिड भी स्टमक में था, इडली डोसा भी स्टमक में ही था, कुछ भी ड्यूडनल अल्सर की तरफ नहीं आ रहा था, इसलिए आकाश अंबानी साहब सो रहे थे। लेकिन जैसे ही ये काइम उतर के ड्यूडनम में आया, या मान लीजिए एसिड उतर के ड्यूडनम में आया, तो ये एसिड उस ड्यूडनम के अल्सर से टकराएगा, या खाना उस अल्सर से टकराएगा, जिसकी वजह से इतना तेज दर्द हुआ रात को 2 बजे की इनकी नींद खुल गई। और फिर ये किचन में गए, 5-6 बिस्किट खाए। जैसे ही 5-6 बिस्किट खाए, ये 5-6 बिस्किट स्टमक में आए, और जो भी एसिड स्टमक में घूम रहा था वो सारा एसिड इन बिस्किट को तोड़ने में इस्तेमाल हो गया। अब कोई फ्री एसिड नहीं बचा ड्यूडनम की तरफ जाने के लिए, तो आकाश अंबानी साहब को दर्द में आराम आ गया और ये फिर सो गए। चूंकि ड्यूडनल अल्सर वाले पेशेंट्स हर 3-4 घंटे में कुछ ना कुछ खाना पसंद करते हैं, इसलिए इनका वजन बढ़ जाता है, मोटे हो जाते हैं। दूसरी तरफ अगर गैस्ट्रिक अल्सर वाले मरीज को देखें, गैस्ट्रिक अल्सर जो है वो बूढ़े लोगों में, गरीब लोगों में बड़े बड़े अल्सर स्टमक में देखने को मिल जाते हैं। अगर स्टमक में कोई बड़ा सा अल्सर पड़ा है और जब भी ये कुछ खाना खाएंगे तो ये खाना सीधा उस स्टमक के अल्सर से टकराएगा, जिसकी वजह से एपिगैस्ट्रियम में जोरों का दर्द होता है। क्योंकि खाना खाते ही इनको दर्द होता है, इसलिए ये खाना खाने से घबराने लगते हैं और इनका वजन कम हो जाता है। आई होप बेटा द कॉन्सेप्ट ऑफ पेप्टिक अल्सर्स is nicely clear in your mind. You can open your eyes and let's have a look at the workbook, what all is written there. जल्दी से अच्छी अच्छी पढ़ाई कर लो बेटा, आकाश अंबानी साहब ओपीडी में आने वाले हैं, राइट? स्टडी वेरी हार्ड, हाँ, यू आर गोइंग टू मीट आकाश अंबानी इन द ओपीडी, राइट? चले जी। सो द पेशेंट्स यूजुअली प्रेजेंट विद एपिगैस्ट्रिक पेन, वेदर इट्स अ गैस्ट्रिक और ड्यूडनल अल्सर. Relation of pain to meals, generally duodenal ulcer pain occurs 2 to 3 hours after meals, while gastric ulcer pain occurs immediately. after meals. Duodenal ulcer pain is relieved by food, while gastric ulcer pain is relieved by vomiting. खाना अल्सर से टकराया इसलिए दर्द हुआ, अगर उल्टी कर दिया तो खाना निकल गया तो दर्द में आराम हो गया. Why? Because gastric ulcer pain was as the food was hitting the ulcer. In vomiting, the food has been thrown out, so now the pain will be relieved. Appetite and weight, duodenal ulcer patients increases, gastric ulcer patient decreases. Regarding blood group association, this is just a data analysis. In the spelling of duodenum, you have got O, and in the spelling of gastric, you have got A. O blood group patients have been found to be more often associated with duodenal. A blood group patients have been found to be associated more with gastric ulcer. Right, beta? Now, just imagine what you will be doing for Akash Ambani Sahab in your OPD. He has come to you with epigastric pain. And you are great doctors. You know the concept. Epigastric pain means stomach duodenal story. Means the story is related to acid. And acid is related to the lifestyle. So, first of all, you will try to do a lifestyle modification. You will try to explain Akash Ambani Sahab that look, you are continuously under stress. That is why the acid secretion inside is more. So try to reduce your tension. Try to reduce your stress. And why he is under stress? Because he is minting crores of money every hour. So the best advice what you can offer to him is, Akash sir, प्लीज हैंड ओवर ऑल योर बिजनेस टू अस. आपका जितना भी बिजनेस है ना वो सारा हमारे नाम पे कर दो, सो दैट इफ यू डोंट हैव मनी, यू डोंट हैव एनी स्ट्रेस एंड योर पेप्टिक अल्सर विल हील. Will Akash Ambani follow this advice? No. If he does not follow the advice, he keeps on minting money, he keeps on having stress, then this duodenal ulcer is not going to heal, right? That is why we say that patients can't afford this lifestyle modification, right? Okay. However, what else we can do, beta? We can give proton pump inhibitors. This is the wonder drug. This is the treatment of choice for all acid related disorders. Or maybe for peptic ulcers, maybe for GRD, maybe for gastritis also, we use these PPIs. 90 to 95% of the times, if you give this medicine to Akash Ambani Sahab, the acid secretion will be blocked and the ulcer will heal. So nothing else will be required. And you can just imagine, you will start receiving gifts from Akash Ambani Sahab worth 1 lakh rupees every day. This is the potential, right? Okay. If by chance this treatment fails, then first investigation what we are doing is a upper GI endoscopy. And with the same protocol, when you do endoscopy, if you find something in the lower esophagus, then you are doing something. If you find something inside the stomach, then you are doing something. If you are doing something inside the duodenum, then you are doing something. If H. pylori turns out to be positive, then you are giving the eradication therapy. And then the story will settle. If by chance the symptoms recur even after eradication of H. pylori, then the first thought which should come to your mind is that there can be reinfection with H. pylori. Reinfection with H. pylori, so you have to give re-eradication therapy. This is our approach, beta, in peptic ulcer patients. The same approach what we have been following in GRD, gastritis and peptic ulcer. First lifestyle, then PPIs. If that does not help, then endoscopy. Depending on what you get on endoscopy, you are proceeding accordingly. If you have taken a biopsy and H. pylori is positive, you give eradication therapy. If the patient is relieved of the symptoms, there is a symptom-free period. Again, suppose the patient present with symptoms, then first thought which should come to your mind is again the reinfection with H. pylori has occurred. So again you have to give eradication therapy for H. pylori. If this also fails, that means now no medicine is working. PPIs have been tried like anything. Eradication therapy has already been given twice to this patient. If the patient is still coming with symptoms, that means now you have to think of doing some surgical intervention. Now you have to think of doing some surgical intervention. Right. So you have to do some surgery. What surgery we are supposed to do? Depends. Whether it's a duodenal ulcer or a gastric ulcer. Suppose we talk about the duodenal ulcer story. Acha beta, what is the culprit in duodenal ulcer? Is it the HCl or is it the mucus barrier? It is the HCl. Acha, who produces HCl beta? HCl कौन बनाता है? Parietal cells. You have already tried PPIs, but they are not working. So now you want to reduce the acid secretion from parietal cells. If PPIs are not working, then yeah, there are two more people who stimulate this parietal cell. One was gastrin, another is vagus nerve also beta. So vagus nerve, if we just try to take a look at the vagus nerve, suppose this is the trunk of the vagus nerve. And now this trunk divides into two. One is the secretory vagal fibers. These secretory vagal fibers are going towards the parietal cells and they are stimulating the parietal cells to produce acid. There are another fibers of the vagal which are the motor fibers. They are mainly going towards the antrum and the pylorus, also to some extent towards the body and to other areas as well. Okay, so this yellow story what you are seeing beta, we are just trying to understand the vagus nerve. There are secretory fibers. This is the trunk of the vagus nerve. There are secretory fibers which stimulate the parietal cells for HCl, acid secretion. They are called as nerves of Grassi. Nerves of Grassi. And beta, there are motor fibers. Motor fibers of vagus, which are called as nerves of Letarsat. Motor means responsible for muscle movement. That means it is these fibers which stimulate the contraction of the gastric muscle and that helps in moving the food down. These are nerves of Letarsat. These are distributed like crow's foot. जैसे कौवे का पंजा होता है, दिस इज व्हाट इज अ क्रोज फुट, उस तरह से ये डिस्ट्रीब्यूटेड है. So this is just a distribution of the vagus now what we are trying to understand. Now, in surgery for duodenal ulcer beta, we want to reduce the acid secretion. That means we want to remove the stimulus of the parietal cells, right? So we want to actually remove these nerve fibers which are supplying to the parietal cells. If you can chop or cut these nerve fibers, then the parietal cells will not be stimulated and HCl production will not be there, right? हमें करना क्या है बेटा? वेगस के फाइबर्स जो पैराइटल सेल्स को सप्लाई कर रहे हैं जो पेराइटल सेल्स को मोटिवेट कर रहे हैं एसिड निकालने के लिए, हमने लेके उनको उड़ा दिया। जैसे आप उड़ा दोगे मोटिवेशन खत्म हो जाएगा, पेराइटल सेल नहीं बनाएंगे एसिड। अगर एसिड नहीं बनेगा तो इस अल्सर को कोई डैमेज नहीं करेगा और ये अल्सर अपने आप हील हो जाएगा, है ना। इफ देयर इज नो एसिड देन दिस अल्सर विल हील स्पॉन्टेनियसली। दैट इज व्हाट वी वांट टू अचीव। If we take a look at the history of the different types of vagotomies, actually what the surgeons did earlier, surgeons लोग ने बेटा पहले पता है क्या किया, they wanted to chop the vagus at this area. First they chopped the vagus at this area, इधर काटा उन्होंने। Here when the vagus was chopped at this area, agreed that parietal cell stimulation was gone, but at the same time the motor movements also gone. That means if we are cutting the vagus at the trunk level, that is the truncal vagotomy, agreed that HCl secretion goes down, but at the same time the stomach contractions also goes down. So if we are doing a truncal vagotomy, the complication which occurs is whatever patient is eating, suppose he is taking idli dosa, after a vagotomy what will happen to idli dosa? This idli dosa will remain inside the stomach only. The stomach muscles are not contracting and they are not able to throw the idli dosa out, right? So this idli dosa will be there inside the stomach only. This is a problem. And whenever we are doing a truncal vagotomy, we have to do another operation so that idli dosa can go down. What we can do is we can make a cut on the pyloric muscles, relax the pylorus area, that is the pyloroplasty, relax the pylorus so that idli dosa goes down. Or you can just take the help of that Sharif Admi, the innocent guy. You can bring that jejunum and connect it with the stomach so that the idli dosa from the stomach can go into the jejunum. That is a gastrojejunostomy. Whenever we are chopping the trunk of the vagus nerve, because of gastric stasis, we have to do a drainage operation either in the form of pyloroplasty or gastrojejunostomy. I repeat this in Hindi beta. जब भी हम वेगस को ट्रंक से उड़ाते हैं तो सेक्रेटरी फाइबर्स भी खत्म हो जाते हैं और मोटर फाइबर्स भी खत्म हो जाते हैं। अगर सेक्रेटरी खत्म होते हैं तो एसिड सेक्रीशन तो कम हो गया, लेकिन अगर मोटर भी उड़ गए तो स्टमक के मूवमेंट भी खत्म हो गए। इसका मतलब इस ऑपरेशन के बाद जब भी पेशेंट खाना खाएगा, मान लो इडली डोसा खाया, तो इडली डोसा स्टमक के मूवमेंट्स ही नहीं है तो इडली डोसा नीचे जाएगा कैसे? तो हमें एक और ऑपरेशन करना पड़ता है इसी के साथ। या तो हम जो पाइलोरिक स्फिंक्टर है, इसकी जो मसल है उसको काटते हैं और इस पाइलोरस को ऐसे चौड़ा देते हैं तो जो भी इडली डोसा है वो नीचे उतर जाए, या फिर हम वो शरीफ आदमी को पकड़ के ले आते हैं और स्टमक को शरीफ आदमी से कनेक्ट कर देते हैं जिससे इडली डोसा सीधा शरीफ आदमी में आ जाए। गैस्ट्रोजेजुनोस्टोमी, दिस इज ड्रेनेज ऑपरेशन। बट देन सर्जन्स they did this truncal vagotomy like anything. Then they realized कि boss, why to chop the trunk of the vagus now? Let us try to preserve the fibers which are going towards the pylorus. So then the surgeon started chopping the vagus now at this area. This was called as a selective vagotomy. But even in doing this selective vagotomy, some motor fibers were gone, so the chances of stasis was still there. Now what we are doing is, we are doing a selective vagotomy now. In this selective vagotomy, we are actually selectively identifying which fibers of the vagus are going towards the parietal cells. And then we are chopping only those fibers. This is called as highly selective vagotomy or parietal cell vagotomy. अब हम लोग क्या करते हैं बेटा, चुन चुन के उन नर्व फाइबर्स को उड़ाते हैं जो पेराइटल सेल्स को ही जा रहे हैं। इसको अपन बोलते हैं हाईली सेलेक्टिव या पेराइटल सेल वेगोटमी। इससे फायदा क्या हुआ? व्हाट इज द एडवांटेज? You have preserved the motor fibers, so the movements of the stomach will not be hampered and the gastric stasis will not be there. There is no need to do any drainage operation if you are doing a highly selective vagotomy. Right, beta? So three types of vagotomies: truncal, selective, highly selective. What is the surgical treatment of choice? Highly selective, right? Drainage operation required or not in highly selective? No. Right, beta ji. So surgical treatment for duodenal ulcer. Treatment of choice is a highly selective vagotomy. Highly selective vagotomy. This is also called as parietal cell vagotomy. No drainage operation is required if you are doing a highly selective vagotomy. This is also called as parietal cell vagotomy. The other types of vagotomies which we have been doing earlier, selective and truncal vagotomy. In this, drainage operation is required. Either we are doing a pyloroplasty or gastrojejunostomy. Either a pyloroplasty or a gastrojejunostomy. Now beta, if we talk about gastric ulcer surgery, what surgery should be done for gastric ulcer? If we take a look at the etiopathogenesis, so gastric ulcer is because of disruption of the mucus barrier. Whether it was H. pylori toxins who were damaging the barrier or maybe NSAIDs or whatever. If the barrier is damaged, whatever acid is there inside the stomach, that will cause damage to the stomach mucosa, right? Now, ideally, we should replace this barrier. So in gastric ulcer patients, we also recommend to take these patients some sucralfate type of medicine which forms a coating on the surface of the stomach, and maybe it does not allow the contact of acid with the stomach mucosa. But if we have to talk about surgery for gastric ulcer, one thing which we know is gastric ulcers have high chances of becoming cancer. There was a time when it was said that gastric ulcers should always be considered as malignant unless proven otherwise. एक जमाना था जब हम ये मानते थे कि अगर स्टमक के अंदर अल्सर है तो इसको कैंसर ही मान के इसका इलाज करिए, जब तक ये नॉन कैंसर प्रूव ना हो जाए. So if gastric ulcers have high chances of becoming malignant, we cannot take any chances. So we actually focus on removing that part of the stomach which is having the ulcer. जो ट्रीटमेंट है गैस्ट्रिक अल्सर्स का, हम यही मान के कर रहे हैं कि ये अल्सर नहीं, ये कैंसर है, और इसके लिए हमें स्टमक का वो हिस्सा निकालना पड़ता है जिसमें अल्सर होता है. ये जो अल्सर बनते हैं स्टमक में, ये यूजुअली पाइलोरस की तरफ होते हैं, बिल्कुल पाइलोरस के नज़दीक. अगर हम देखें, अगर ऊपर हमारा डायग्राम है तो हम यहाँ देख सकते हैं कि ये जो स्टमक में अल्सर दिखाई दे रहा है, ये बिल्कुल पाइलोरस के बाजू में है. These stomach ulcers, they are very close to the pylorus. So, if we are considering them as malignant, we want to remove this part of the stomach which is having the ulcer. तो सर्जरी में क्या करेंगे बेटा? We are going to remove this whole part of the stomach. ये पूरा स्टमक का हिस्सा हम निकाल देंगे. And we'll be left only with this part of the stomach. And then we'll see whether we can connect it with the duodenum or the jejunum. तो देख लेते हैं. If this is the esophagus and this is the stomach. So here what we have done beta, we have actually removed the distal part of the stomach. निकाल दिया. अभी हमारे पास क्या बचा बेटा? अभी हमारे पास duodenum बचा. ऐसा इसको ऐसे बनाते हैं. We have got this duodenum here, and then there is a jejunum beta. We very well know that in this area lie the pancreas, beta. And this pancreas is inseparably fused with the duodenum. So we cannot separate the duodenum from the pancreas. That is the reason why it is difficult to mobilize the duodenum. Actually, when the surgery started for this stomach ulcers, the famous Russian surgeon Bill Roth, he initially tried to connect the stomach with the duodenum. He tried to make this connection. This was a Bill Roth 1, that is gastroduodenostomy. Can you appreciate this, beta? This is a gastroduodenostomy, and this was Bill Roth 1. But what happened? Because the duodenum was far from the stomach, the anastomosis was under tension and the sutures broke and the anastomosis leaked. If the anastomosis leaks, then the gastric contents or the duodenal contents, they will leak into the peritoneal cavity. That will lead to peritonitis, septicemia, and patient will die. Because of this reason, this gastroduodenostomy is not done. Another simple concept in surgery, beta, there should not be any kind of tension in surgery, neither while doing surgery nor while reading surgery. I repeat this in Hindi. सर्जरी में बेटा कभी भी टेंशन नहीं होनी चाहिए, ना सर्जरी पढ़ते समय ना सर्जरी करते समय। टेंशन के काम खराब होते हैं। जब जब हमने ऑपरेशन में जोड़ ऐसे लगाए हैं जिस जोड़ में टेंशन होगी वो जोड़ खुल जाते हैं। Whenever we are doing any anastomosis which is under tension, then because of this tension the anastomosis leaks, right? That is why this Bill Roth 1 gastroduodenostomy failed. And then Bill Roth realized, oh, so I should not connect the stomach with the duodenum. I have got one innocent guy, and that is the jejunum. So let me chop the jejunum from here and let me take this jejunum here and do the anastomosis. So Bill Roth took this jejunum here and did the anastomosis. Right? This was called as gastrojejunostomy. This is Bill Roth 2. Acha beta, you also know that bile duct is opening here and the pancreatic duct is opening here. That means bile and pancreatic juice are coming here. Idli dosa is coming here. So idli dosa has to be mixed with bile and pancreatic juice. Then only idli dosa will be digested. So idli dosa is coming here, right? Bile and pancreatic juice is coming here. So we have to connect this jejunum with this jejunum. This should be called as jejunostomy. Now can you see the bile coming here, beta? The bile and pancreatic juice, they are coming here. The idli dosa is coming here. And this idli dosa is getting mixed with bile and pancreatic juice, so this will be digested properly and the story will be normal. Since this is forming a letter Y, we call it as Roux-en-Y gastrojejunostomy. Roux-en-Y gastrojejunostomy. This is the primary anastomosis, so this is what we use in these anastomosis. Surgical treatment of choice. Is Roux-en-Y gastrojejunostomy. Aim in the surgical treatment for gastric ulcer is to remove the ulcer bearing part of stomach. Remove the ulcer bearing part of stomach. while aim in the treatment of duodenal ulcer here the aim is reduce the acid secretion. Aim in the treatment for duodenal ulcer is reduce the acid secretion, while aim in the treatment for gastric ulcer is remove the ulcer bearing part of the stomach. Nowadays we are doing a Roux and White gastrojejunostomy. Earlier Billroth 1 gastroduodenostomy, Billroth 2 gastrojejunostomy. Whenever we are doing these surgeries, beta, there can be some complications of these surgeries. For example, look at the screen carefully. This what you are seeing is the duodenal stump. Here you would have put the sutures and closed the duodenal stump. You know there is bile and pancreatic juice coming in this area. So sometimes what happens, beta, maybe fourth, fifth day after the operation, sometimes there is more pressure of bile and pancreatic juice in this area, and this pressure is putting pressure on these sutures, and these sutures break. If these sutures break, all this bile pancreatic juice will leak into the peritoneal cavity, leading to peritonitis, septicemia, and death. This is what we call as duodenal stump blowout. Duodenal stump blowout. क्या बोलते हैं बेटा इसको? Duodenal stump blowout. Right? The stump blows out. So the bile pancreatic juice can leak. This can occur on 4th and 5th post-op day. Another complication, beta, which is quite commonly asked in your exams nowadays. 4th of June 2022 also there was a question on dumping syndrome. Dumping means what? Dumping means somebody has dumped someone. Okay? Why? Look at the screen carefully, beta. This is the operation. Suppose what you have done. You have connected the stomach directly with the jejunum. You know there is no pylorus here. Before this surgery, beta, when pylorus was there, whatever food used to come inside the stomach, that used to stay here for 2 to 3 to 4 hours. But now, if there is no sphincter, no control, whatever food is coming into the stomach, that will not stay inside the stomach for a longer time. That food will immediately pass down into the jejunum, maybe within 5 to 10 minutes only. So the food is getting dumped into the jejunum directly. If we try to understand what used to happen earlier, let us take a look at the video first.
Dumping syndrome is a very common complication following gastric and esophageal surgeries. Also known as rapid gastric emptying, dumping syndrome is a condition in which undigested food moves too quickly from the stomach to the small intestine. In other words, food gets dumped into the intestine before being properly digested. This happens because the valve that separates the stomach and the small intestine, called the pyloric sphincter, was either removed or damaged in the surgery. There are two forms of the disease, based on when symptoms occur, early or late. Early dumping happens between 10 to 30 minutes after a meal. Symptoms arise as the rapid dumping of the undigested, concentrated food mass triggers the body to move fluid from the bloodstream into the intestine in an attempt to dilute the food. The resulting distended intestine produces bloated feelings, abdominal cramps, nausea, vomiting, and diarrhea. This shift of fluid, when excessive, may also significantly reduce blood volume, causing rapid heart rates, dizziness, lightheadedness, or even fainting. Late dumping symptoms occur within 1 to 3 hours after eating. At this point, the rapid increase in sugar absorption triggers the pancreas to produce more insulin. in an attempt to prevent too high levels of blood glucose. However, it may overreact and produce too much insulin, causing instead too low blood glucose levels or hypoglycemia, which may manifest as weakness, sweating, confusion, and tremors. Increase in gastrointestinal hormones is also observed and thought to contribute to both early and late symptoms. Symptoms are often more severe after meals that are high in simple carbohydrates, such as table sugar. Most cases of dumping syndrome can be successfully managed with diet changes. These include eating smaller meals throughout the day, avoiding foods with high simple sugar content, choosing foods that are rich in proteins, fibers, and complex carbohydrates, delaying liquid intake until at least 30 minutes after a meal, adding thickening agents to increase food consistency. If these fail, medications that slow down gastric emptying or inhibit insulin release may be prescribed. Tube feeding that bypasses the upper digestive tract or corrective surgery, such as reconstruction of the pyloric sphincter, may be performed as a last resort. Syndrome is a condition in which undigested food moves too quickly from the stomach to the small intestine. In other words, food gets dumped into the intestine before being properly digested. This happens because the valve that separates the stomach and the small intestine, called the pyloric sphincter, was either removed or damaged in the surgery. There are two forms of the disease based on when symptoms occur, early or late. Early dumping happens between 10 to 30 minutes after a meal. Symptoms arise as the rapid dumping of the undigested, concentrated food mass triggers the body to move fluid from the bloodstream into the intestine in an attempt to dilute the food. The resulting distended intestine produces bloated feelings about surgery. Nausea. There are two forms of the disease based on when symptoms occur. Shift early or late in excessive early may also have significantly reduced blood volume after causing rapid heart rates, dizziness, lightheadedness, or even fainting. Late dumping symptoms occur within 1 to 3 hours after eating. At this point, the rapid increase in sugar absorption triggers the pancreas to produce more insulin in an attempt to prevent too high levels of blood glucose. However, it may overreact and produce too much insulin, causing instead too low blood glucose levels or hypoglycemia, which may manifest as weakness, sweating, confusion, and tremors. Increase in gastrointestinal hormones is also observed and thought to contribute to both early and late symptoms. Symptoms are often more severe after meals that are high in simple carbohydrates, such as table sugar. Most cases of dumping syndrome can be successfully managed with diet changes. These include eating smaller meals throughout the day, avoiding foods with high simple sugar content, choosing foods that are rich in proteins, fibers, and complex carbohydrates, delaying liquid intake until at least 30 minutes after a meal, adding thickening agents to increase food consistency. If these fail, medications that slow down gastric emptying or inhibit insulin release may be prescribed. Tube feeding that bypasses the upper digestive tract or corrective surgery, such as reconstruction of the pyloric sphincter, may be performed as a last resort.
Right, beta, perfect. I was just trying to see whether the audio was going into you or your videos or not. So I think that's a wonderful explanation regarding what is dumping. But still, let us try to understand it even more. Suppose, beta, we are talking about this type of story. Now, just focus on the screen. Right. This is what is before the operation, beta. When the idli dosa is coming here, it is getting broken down into small, tiny bits and pieces. And by the time the idli dosa comes into the jejunum, it has already broken into small, tiny bits and pieces. We know that absorption starts in this duodenum area, and majority of the absorption is also going to take place in the jejunum. To absorb these nutrients, blood is required. In normal individuals, beta, in all of us, what happens? Whenever these tiny bits and pieces reach the jejunum, whatever blood is present in this area, that is usually sufficient, or maybe some blood can be borrowed from here and there, and this blood is sufficient to absorb the important nutrients from this food, right? So we don't even come to know that when the food which we have swallowed that has reached into the jejunum, because that is something which is going on naturally. Now, after this operation, beta, what you can see here, after this operation, if I just remove myself so that you get a good idea what the operation is this all about. Right. So now if we just try to understand this, okay, if you have connected the stomach directly with the jejunum, whatever food is there, that is directly coming into the jejunum. So the food is actually getting dumped into the jejunum, and jejunum is getting confused. Ki, what the hell is this? These are not tiny bits and pieces. The food has not remained inside the stomach for a longer time. So the food has not been broken down. This bulky food comes into the jejunum, and the jejunum is getting confused that how to absorb the nutrient from this bulky food. So as soon as the food comes into the jejunum, within 5 to 10 minutes after the meal, the jejunum sends signals to the entire body, ki please send blood to me. I don't know who the alien from other planet has come here, how to absorb the nutrients from this bulky meal. So immediately after meals, or maybe 5 to 10 minutes after meals, there is migration of blood from the peripheries towards the jejunum to facilitate absorption of nutrients. Because there is migration of huge amount of blood towards the jejunum, there is fullness in the jejunum, right? And this gives a bloating, epigastric cramp type of story. Because the periphery blood has been diverted, so peripheries will become cold. The patient sweats. Sometimes because the intravascular volume is going down, and the patient might have tachycardia. Patient might have dizziness or fainting type of stories. This is what is a early dumping. Late dumping is something related to insulin, beta. Before the operation, what used to happen? Food was broken down here, only small, tiny bits and pieces. This used to send signal to the pancreas to release the insulin, so that whatever glucose has come into the blood, that glucose can be deposited into the cells. So since these were tiny bits and pieces, tiny glucose, tiny insulin, and the glucose was deposited in the cells. But here what is happening? Bulky food, bulky stimulation to the pancreas, bulky secretion of insulin. Actually speaking, if you compare the capacity of the two stomach, before operation the capacity is more. So this patient was eating more. The requirement of insulin was more in this patient. But what has happened in this patient? That though the requirement, the amount of meal taken is less, the requirement of insulin should have been less. But because the food has not been digested properly, bulky food here has given a bulky demand to the pancreas and bulky secretion of insulin. Excess insulin will cause hypoglycemia. So usually in the second hour after meals, the patient develops hypoglycemic symptoms, fainting, tremors, right? To treat hypoglycemia, we have to again give glucose. As soon as you give glucose to these patients, again there is a early dumping and then late dumping, then again early dumping, then late dumping. So it becomes a vicious cycle. ठीक है? That is the problem. Now I would like to explain this story in Hindi also once. डंपिंग का मतलब क्या है बेटा? किसी ने किसी को डंप कर दिया. पहले खाने स्टमक में रहता था 3-4 घंटे, खाने की अच्छे से कुटाई पिटाई होती थी, और जब तक खाना जेजुनम में पहुंचता था तब तक वो कोटा पिटा छोटे छोटे से दाने दाने जैसे पहुंचते थे. लेकिन अगर मान लो अपन ने ये वाली सर्जरी की जिसमें स्टमक को डायरेक्टली जेजुनम से कनेक्ट कर दिया, तो भैया खाने को स्टमक में रुकने का वक्त तो मिल नहीं रहा. 5-10 मिनट के अंदर ये खाना फटाक से जेजुनम में आ जाएगा, यानी खाने का ब्रेक डाउन नहीं हुआ. हमारे बड़े लोग कहते हैं ना बेटा कि जब भी आप खाना खाते हैं बातें नहीं करनी चाहिए. क्यों? खाने को अच्छे से चबा चबा के क्यों खाना चाहिए? क्योंकि अगर आप नहीं चबाओगे तो खाना ऐसे का ऐसा जाएगा, तो नीचे जो लोग हैं, स्टमक है, ड्यूडनम है, जेजुनम है, इन लोगों को मेहनत ज़्यादा करनी पड़ेगी. तो उनकी मेहनत को कम करने के लिए मुंह की मेहनत ज़्यादा करानी चाहिए. अच्छा बेटा, मान लो कि ये बल्कि मील जो था ये सीधा जेजुनम में पहुंच गया. अब जेजुनम को तो इसकी आदत नहीं है, जेजुनम को तो वो छोटे छोटे पीसेस की आदत है. यहाँ तो पूरा का पूरा बड़ा सा रसगुल्ला पहुंच गया है. अब जेजुनम कंफ्यूज हो जाता है कि भैया अब मैं इससे न्यूट्रिएंट्स कैसे एब्जॉर्ब करूं. तो जेजुनम पूरी बॉडी को सिग्नल भेज देता है कि जिसके पास जितना ब्लड है तुरंत मेरे पास भेज दो. तो खाना खाने के 5-10 मिनट के अंदर पूरी बॉडी से खून जो है माइग्रेट करके इंटेस्टाइन में आना शुरू हो जाता है. उससे ये इंटेस्टाइन की ऐसी फुलनेस सी होने लग जाती है, पेट ऐसा भारी होने लग जाता है, फूलने लगता है, एपिगैस्ट्रिक फुलनेस होने लगती है, एपिगैस्ट्रिक पेन होने लगता है. और चूंकि पेरीफेरी से ब्लड सारा जीआईटी में आ गया है, तो यानी पेरीफेरी में खून कम हो गया है, तो पेरीफेरी ठंडे पड़ने लगते हैं, स्वेटिंग सी होने लगती है. और जब इंट्रावेस्कुलर वॉल्यूम कम होने लगेगा तो हार्ट भी तेजी से धक धक करने लगता है. तो यानी खाना खाने के 5-10 मिनट के अंदर ये जो कहानी हमें देखने को मिल रही है, इसको अपन बोलते हैं अर्ली डंपिंग. और ये तब ज्यादा होती है जब हम शुगर कंटेंट जिसमें ऑस्मोटिक लोड ज्यादा होता है ऐसे खाना खाते हैं. ठीक है, जैसे जूस वगैरह है. ठीक है. लेट डंपिंग जो है वो खाना खाने के दूसरे घंटे में देखने को मिलती है, और उसकी कहानी इंसुलिन और ग्लूकोज से रिलेटेड है. नॉर्मली क्या होता था, ऑपरेशन से पहले जब ये छोटे छोटे पीसे आया करते थे यहाँ पे, तो थोड़ी बहुत रिक्वायरमेंट जो भी इंसुलिन की होती थी, जेजुनम पैनक्रियास को बोल देता था भाई जरा सा भेज दियो, तो पैनक्रियास इंसुलिन भेज देता था और वो इंसुलिन इस ग्लूकोज को सेल्स में डिपॉजिट करा देता था. लेकिन इस ऑपरेशन के बाद गड़बड़ क्या हो गई कि यहाँ तो पूरा का पूरा रसगुल्ला मान लो आ गया है. तो अब जेजुनम भाई साहब कंफ्यूज हो गए हैं कि भैया इतने बड़े रसगुल्ले को मैं कैसे डिपॉजिट कराऊंगा. तो जेजुनम तुरंत पैनक्रियास को बोलता है कि भाई तेरे पास जितना इंसुलिन पड़ा है उतना तो अभी भेज दे, और बाकी फटाक से बनाना चालू कर दे. पता नहीं कौन सा एलियन आया किसी दूसरे प्लेनेट से, इसको कैसे ग्लूकोज को ठिकाने लगाए. तो पैनक्रियास भी भाई साहब जो है इंसुलिन बहुत ज्यादा भेज देते हैं. अब एक्चुअली में देखा जाए तो भैया कैपेसिटी देखो स्टमक की, ऑपरेशन से पहले और ऑपरेशन के बाद कैपेसिटी पहले ज्यादा थी. मतलब खाया तो पहले ज्यादा होगा, यानी इंसुलिन की जरूरत तो पहले ज्यादा होनी चाहिए. यहाँ तो बेचारे ने क्या खाया होगा, इंसुलिन की रिक्वायरमेंट कम होनी चाहिए, लेकिन इंसुलिन का जो सेक्रीशन हो रहा है वो ज्यादा हो रहा है. अब अगर इंसुलिन ब्लड में ज्यादा हो जाएगा तो जितना ग्लूकोज डिपॉजिट करना था वो तो हो गया. अब बाकी इंसुलिन क्या कहता है, लाओ भैया खाना लाओ, ग्लूकोज लाओ. कैसे डिपॉजिट करूं, ग्लूकोज है ही नहीं ब्लड में. तो पेशेंट को हाइपोग्लाइसेमिक सिम्टम्स चालू हो जाते हैं, फेंटनेस, ऐसे बेहोशी छाने लगती है, ट्रेमर्स आने लगते हैं. अब हाइपोग्लाइसीमिया में कोई भी जा रहा है तो अपने को फिर उसको ग्लूकोज देना पड़ता है. मतलब रसगुल्ला खाने की वजह से ये सारा अर्ली डंपिंग लेट डंपिंग हुआ, और लेट डंपिंग के ट्रीटमेंट के लिए फिर रसगुल्ला खिलाना पड़ता है. रसगुल्ले की वजह से समस्या हुई और ट्रीटमेंट में फिर रसगुल्ला खिला रहे हैं, तो फिर से अर्ली डंपिंग, फिर लेट डंपिंग, फिर रसगुल्ला, फिर अर्ली डंपिंग, फिर लेट डंपिंग. तो एक साइकिल बन जाती है. So in the treatment for this dumping syndrome, what we realize is कि it is because of a large meal which is dumped into the jejunum. That is why this early and late dumping is occurring. So what we can do in these patients is, we can ask these patients कि भाई don't take a bulky meal. What you can do is, suppose you want to eat a rasgulla or a idli, what you can do? Don't eat the complete idli. Just cut that rasgulla or idli into 6 or 7 pieces. One idli, 6, 7 pieces. And take one piece of that idli in 2 hours or 3 hours. Every 2 to 3 hours, take only one piece of idli, so that the jejunum will not be overstimulated and the patient will not develop that dumping syndrome. Moral of the story, the treatment for dumping is small frequent meals. Small frequent meals. Instead of a bulky meal, we ask the patient कि भैया दिन में 3 बार खाना नहीं, आप 6 बार खाइए, 8 बार खाइए, कम कम खाइए, ज्यादा बार खाइए. Small meals multiple times. चलिए, तो if we take a look here, let us come back to this complication story. Duodenal stump blowout. This occurs on 4th post-operative day. 4th post-op day. Dumping syndrome, also called as post-Seibel syndrome. We can classify this into early dumping and late dumping. Early dumping is due to high osmotic load. High osmotic load in intestine. And late dumping is due to reactive hypoglycemia. Late dumping is due to reactive hypoglycemia. We can just make a note. Early dumping this occurs within 5 to 10 minutes after meals. 5 to 10 minutes after meals. And patient presents with bloating, epigastric pain, tachycardia, and cold peripheries. Early dumping within 5 to 10 minutes after meals. Patient presents with bloating, epigastric pain, tachycardia, and cold peripheries. While late dumping, this occurs in the second hour after meals. There is faintness, tremors. Usually these symptoms of early and late dumping, they remain for 30 to 40 minutes and then gradually they subside. तो आधा पौन घंटे तक पेशेंट को परेशानी होती है. in the treatment for both early as well as late dumping, the treatment is small frequent meals. Small frequent meals. There are some other complications which we can see, like there is post-vagotomy diarrhea. The reason for this is not known. There may be nutritional deficiencies. Again, there was a question for these nutritional deficiencies which we see in this bariatric surgery, or you can say the stomach surgeries. There is protein, calorie malnutrition, then deficiency of iron, vitamin B12, calcium, phosphorus. Various nutritional deficiencies are seen whenever we are doing these type of surgeries. Why you see iron deficiency, beta? Just for a moment, if you just have a look at this image, beta, just have a look. Iron absorption mainly occurs in the duodenum, in this area, right? What has happened? If you are doing this surgery, the food is coming into the stomach and then it is going into the jejunum. The food is actually not going into the duodenum. Iron is here inside the food. So if food is not going into the duodenum, then iron is not getting absorbed. That is the reason why there is iron deficiency. Vitamin B12, since you are chopping some part of the stomach, so if the parietal cell load goes down, then the amount of intrinsic factor released will go down. So this will lead to vitamin B12 deficiency, right? That is why we see these nutritional deficiencies. There is increased risk of gallstone formation and gastric cancer. Here in beta, again, this is very simple to understand. Why these chances of stones in the gallbladder will increase after gastric surgery. If you look at this particular picture, beta, can you see these motor fibers are going somewhere else also? Actually, these are also going towards the gallbladder. Whenever you are doing any stomach surgery, then obviously these fibers are also getting destroyed. So if those fibers are destroyed in gastric surgery which are going towards the gallbladder, and these are motor fibers, that means these fibers are responsible for contractions of the gallbladder. If you have chopped these fibers, gallbladder contraction will not occur. That means gallbladder will not be able to pump the bile out. That means the bile will stay inside the gallbladder. Stasis, infection, stone formation. I repeat this in Hindi, beta. जब भी हम स्टमक का ऑपरेशन करते हैं जिसमें ये वेगस के मोटर फाइबर्स उड़ाए जाते हैं, अगर हमने वो वेगस के फाइबर्स उड़ा दिए जो गॉल ब्लैडर को मोटर सप्लाई कर रहे थे, तो गॉल ब्लैडर के मोटर कॉन्ट्रैक्शंस कम हो जाएंगे. अगर गॉल ब्लैडर के कॉन्ट्रैक्शंस कम हो गए मतलब गॉल ब्लैडर पंप नहीं कर पाएगा, यानी कि गॉल ब्लैडर के अंदर जो बाइल है वो वहीं का वहीं रुका रह जाएगा. स्टेसिस की वजह से इन्फेक्शन होगा और इन्फेक्शन की वजह से पत्थर बन सकते हैं. तो ये कारण है कि क्यों गॉल स्टोन्स बनते हैं. और बेटा कैंसर होने का खतरा क्यों है ये हम बहुत अच्छे से जानते हैं. व्हाई देयर इज इंक्रीज रिस्क ऑफ कैंसर आफ्टर गैस्ट्रिक सर्जरी? सिंस देयर इज नो पाइलोरस हियर, the jejunal contents will reflux into the stomach, will cause reflux gastritis, alkaline gastritis, intestinal metaplasia, and adenocarcinoma of the stomach. So that is how these different type of complications can be seen after this gastric surgery. This is what we talked about, the complications of surgery. Now if we talk about the complications of peptic ulcer, ulcer के क्या complications हो सकते हैं? So there are three small little complications. For example, ulcers can bleed, ulcers can perforate, and ulcers can also cause stenosis. Ulcers can also cause stenosis. So there are three complications. Simple bleeding. Why there is bleeding? If suppose there is a duodenal ulcer on the posterior surface of duodenum. Suppose करते हैं बेटा that this is the duodenum. ठीक है बेटा, this is, just imagine this is the first part of duodenum. Now this what you are seeing is the anterior surface of duodenum, right? This what you are seeing is the anterior surface, and behind what I am seeing is the posterior surface. Now here on the posterior surface beta, here on the posterior surface there is a gastroduodenal artery which is passing. On the posterior surface of duodenum there is a gastroduodenal artery which is passing. If there is an ulcer on the posterior surface of duodenum, this ulcer can penetrate into the gastroduodenal artery and it can start bleeding. Bleeding most commonly in duodenal ulcer is from gastroduodenal artery. So bleeding most commonly seen in duodenal ulcer. In hematemesis also we saw the commonest cause of hematemesis was peptic ulcer, duodenal ulcer. Most commonly ulcers which are situated on the posterior surface of first part of duodenum, they bleed, and most commonly it is the MCQ artery which bleeds. Gastroduodenal artery. It is the gastroduodenal artery which bleeds. Now if bleeding is taking place inside, we all can understand that this blood, here it is the pylorus, so the chances of going this blood into the stomach are not very high, but yes, the chances of blood going down are very high, and by the time it goes down, then gradually this hemoglobin starts disintegrating and it can become brown, or finally it can even become black. So the patient will pass black tarry stool, which we call as melena. So this is how these patients can present to us. Melena. Gastric ulcer bleeding is rare. If gastric ulcer bleed occurs, it is from left gastric artery. Sometimes what can happen beta, these peptic ulcers, they can perforate, and usually the ulcers which are present on the anterior surface ulcers, they have more chances of perforation. We all can understand beta, if the ulcer perforates, the inside masala will leak into the peritoneal cavity, will lead to peritonitis, septicemia. The patient will have diffuse abdominal pain, nausea, vomiting. Patient may present with shock-like condition. In these cases, first thing what we are supposed to do is basic resuscitation. That means we have to pump in IV fluids to save the life. We do the clinical examination and we find a cardboard-like rigidity in peritonitis. Cardboard-like rigidity in peritonitis. जब भी पूरे पेट में ऐसे जहर फैल जाता है, ऐसे इन्फेक्शन हो जाता है, whenever the entire abdomen is getting involved by this septic load, then the entire abdominal wall, the muscles of the abdominal wall, they try to resist any pressure from outside. So when you are doing the clinical examination, the abdominal muscles become rigid. A diffuse rigidity, just like a cardboard, is what we can see in peritonitis. One of the most important x-rays, very high probability, 17th of December. Whenever there is hollow viscous perforation, hollow viscous matlab GIT का कोई भी हिस्सा, whenever there is a hollow viscous perforation right from mouth to anus, there will be leakage of air. If this hollow viscous is in the thorax, leakage of air into the thorax, pneumomediastinum. If this hollow viscous is in the abdomen, leakage of air in the peritoneal cavity, pneumoperitoneum. And whenever we talk about pneumoperitoneum, that is air, free air in the peritoneal cavity, air always rises up. So we can see this air in the abdomen on a chest x-ray. Chest x-ray is usually taken in a standing position beta. This is a hot x-ray, repeated multiple times in the last 5 exams in FMG as well as NEET PG. अभी यहाँ पे अगर हम देखें बेटा, तो this thing what you are seeing here, this is the diaphragm. Just carefully have a look beta. This what you are seeing here, this is the diaphragm. Can you see a black shadow beneath the diaphragm? This black shadow what you are seeing here, This is the free air in the peritoneal cavity. The patient is in a standing position, so this free air has risen up, and we are looking for this free air on the right side beneath the right dome of the diaphragm. Why beneath the right dome? Because if we focus on the left side, then there is already a normal stomach bubble which we can see on the left side. This is a normal stomach bubble on the left side. So we do not want to confuse ourselves. It is better that we look beneath the right dome of the diaphragm, and here we can find that there is gas beneath the right dome of the diaphragm. This simply means there is a hollow viscous perforation, maybe gastric, duodenal, jejunal, ileal or colonic perforation. कुछ भी हो सकता है. Another picture showing gas in the diaphragm. So on X-ray, what we find is a pneumoperitoneum. If suppose the patient is not able to stand and we cannot take a chest X-ray, then we ask the patient to lie down. Now, if the patient is lying down, the gas will rise up and you will see the gas beneath the umbilicus area. If you want to see the gas properly, you can ask the patient to turn on one side. On which side the patient should be turned? Should it be right turning, that is right lateral decubitus, or it should be left lateral decubitus? If you turn the patient on the right side, that means right side is down, left side is up. So gas will rise towards the left side, and on the left side in the upper abdomen there is a stomach shadow already. So we can confuse with the stomach shadow if you are taking the X-ray in a right lateral decubitus. So better to turn the patient on the left side. So gas rises up towards the right side and you look on the right side. There is no confusion, no stomach shadow on the right side. So if you have to take a X-ray in a supine position, it is better to take the X-ray with the patient turned in the left lateral decubitus position, right? Fine. Now in the treatment, what we have to do is, since this is a gastric or duodenal perforation, the masala has leaked into the peritoneal cavity, there is a risk of septicemia. Just what we talked in Bohr-Havi syndrome, same concept we'll apply here. We have to save the life of this patient. We have to remove the septic load. So we'll do a laparotomy, do a nice jhadu pocha, Modi ji Swachh Bharat Abhiyan, peritoneal lavage. This is going to be life-saving for this patient. And once you have done a nice jhadu pocha, nice lavage in the peritoneal cavity, then decision to close or not to close the perforation will depend on the amount of contamination. If there is only minimal contamination, that means if the patient comes to you before 24 to 48 hours, then closure of perforation can be done. Closure of perforation. For closing the gastric or duodenal perforation, we use a omentum patch, omental patch, which we also call as Gram's patch. Gram's patch. In Bohr-Havi syndrome, the timing which you have written is less than 4 to 6 hours. In gastric duodenal perforation, you are writing 24 to 48 hours. And the simple reason is, in Bohr-Havi, what happened was the stomach contracted forcefully. So the amount which has leaked into the mediastinum is very high. That is why we are just taking a small time for minimal contamination, 4 to 6 hours. If the contamination is more, then we just leave the drains. Apart from this, another complication what we can see in these peptic ulcers, जब भी ये जख्म भरते हैं, whenever the ulcer heals, healing occurs by fibroblast, fibrosis, and fibrosis contracts, which leads to strictures or stenosis. Depending on whether the ulcer is healing in a transverse direction or it is healing in a longitudinal direction. If it is healing in a transverse direction, then it gives the appearance of a hourglass stomach. Hourglass stomach is somewhat like this, beta. This what you are seeing is a hourglass stomach. वो एक खिलौना होता है ना जिसको अपन ऐसे खेल लेते हैं, उसमें कुछ भी भरा होता है, right? So that this is what is the hourglass stomach whenever there is a transverse healing. And if suppose it's a longitudinal healing, then the fibrosis makes this area quite narrow and this stomach starts looking like a teapot, जैसे चाय की केतली होती है वैसा कुछ दिखाई देने लगता है. So in a longitudinal healing we can find a teapot type of stomach. In a transverse healing, the hourglass stomach. So these can be the different complications of peptic ulcer. Now beta, another story what we can come here is the different Bezos. And again 4 June 2022 we had a question here. There was an image and they asked that this type of image, a slightly different image was there in the exam. These patients should be referred to whom? So first of all, we should know what is all this about. Single line questions, high scoring questions. Bezor simply means a bag. There are 3 terms: tricho, phyto, lactato. Generally questions are from tricho, maximum from phyto. Tricha means hair. So when there is collection of hairs inside the stomach, that is trichobezor. Phyta is plants, vegetables. When there is collection of vegetable matter inside the stomach, that is phytobezor. Lactato is milk and milk products. Whenever milk products collect inside the stomach, that is lactatobezor. Now, when do we see all these bezors? Trichobezor, how hairs can be seen inside the stomach. It is not that the hair grow inside the stomach, but a very common condition what we have seen is young females who have got some psychiatric disorder. They keep on plucking their hairs and they keep on swallowing their hairs. So gradually a tuft of hair goes down into the stomach, and a day can come when the entire stomach may be full of hairs inside because of the plucking. यहाँ का सिस्टम खाली हो जाता है, यहाँ के बाल खाली हो जाते हैं और ये सारे स्टमक में भर जाते हैं. This huge collection of hair inside the stomach is called as trichobezor. The question asked on 4th of June 2022 was that this was an image given that this female or this patient should be referred to which doctor, and the options were psychiatrist, dermatologist, pediatrician, something like that, right? Just a moment. Okay. Right. So the answer to that question was psychiatrist, right? Okay, beta. So trichobezor is what? Hairs in the stomach, commonly seen in young psychiatric females. And this is the image of trichobezor. Phytobezor is vegetable matter inside the stomach. And lactatobezor is milk and milk products. Why this vegetable matter or milk products get collected inside the stomach? This is due to gastric stasis. Whenever the stomach movements slow down, then there are chances of these matter getting collected inside the stomach. Suppose we get a lunch break of only 10 minutes, suppose. Then we might be going out and we might be eating something very quickly. And that, suppose a cauliflower, that you just gulp that cauliflower. So there are chances that that cauliflower will remain inside the stomach only, right? So that can be a probability. Okay. However, this was just a normal thing what we are trying to understand. Generally, people who are admitted in ICU for long periods, we know in prolonged immobilization, the peristalsis of different systems, they go down, the blood movements, they slow down, so the chances of stasis of food inside the stomach will be high. If you have done a gastric surgery where you have chopped the vagal fibers, again the chances of gastric movements going down are high. So patients who have undergone previous gastric surgery or prolonged immobilization, they have more chances of phytobazor and lactatobazor, while tricobazor is something commonly seen in young psychiatric females. And the last thing for this stomach area is bariatric surgery. This is a surgery for morbid obesity, also called as